स्टार्ट हो गया? हाँ 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 ठीक है बस बढ़िया। Hello student, a very good evening to all of you. I hope I am clearly audible and visible at your end. So we are going to start LRR in physiology. Okay. So this session is specially dedicated for INI-CET examination, as you know, right? So what we are going to do in this LRR session, to the most important topic which you must read before going into your exam hall, right? So those topics we are going to discuss in a crisp manner, right? Okay, so physio as a branch, it is out of the scope of this session. Okay, you can contact me personally for physio as a branch, right? I am there in Insta and YouTube, anywhere you can contact me. But anyway, so what I told ki in this LRR session, what we are going to discuss, I have planned the session in such a way that first we are going to discuss the single one-liner, important one-liner which are important for INI-CET, right? Then we are going to discuss some important mathematical calculation which are important for INI-CET, because you know ki INI-CET is an exam where from physio there are multiple mathematical questions they have given recently also, as well as in the past years also. So those mathematical important calculation we are going to discuss, right? Then we are going to discuss important images. So image is also important part of the INI-CET exam particularly physiology. So the important images which has been asked in the previous year questions, as well as in some new images we are going to discuss here, and then we will put some important tables and some numericals which you have to mug up mostly. Okay, so those information I have kept at the end of this session, right? So it will be a small session, maybe 1.5 to 2 hours, but within this 2 hours we are going to discuss all of this thing. Okay, important one liner followed by mathematical calculation, followed by images, followed by tables and numericals, right? So this is our plan for today. Obviously INI-CET and NEET PG, it is obviously it will be useful for the NEET PG also, because INI-CET and NEET PG questions we have seen that there are multiple overlaps of topics and overlaps of questions between INI-CET and NEET PG, even FMGE also, right? So we are starting the session, but before starting the session I will give you some important suggestions. Okay, so exam ke pehle we generally give suggestions that these are the important topics. So these are the topics which are important for INI-CET. This was in the last LRR also. I have shown these important topics in the last LRR also and here also. So from respiratory physiology, from CVS physiology, if you have to give a last minute revisions, what are the topics you should revise, okay, at the last minute before going to the exam. So these are the list of the topics from respiratory physiology, CVS, neurophysiology, general physiology, renal and GIT and endocrine physiology. Okay, so at least these headings, whenever you are looking at physiology, that which I should read and revise before exam. So these are the things that you may revise before your exam, right? Okay, now PDF मिल जाएगा at the end of the session. PDF मिल जाएगा, लिंक यहाँ पे रहेगा चैट बॉक्स में, जो यूट्यूब का सेशन है उसका कमेंट में देख लेना, लिंक मिल जाएगा, ठीक है? Sound a little bit higher. My actually little irritation is going on in my throat, so that's why I'm speaking a little bit lower voice, but otherwise I think they will increase the voice, I think. I mean, increase the volume please, so they will do it. Okay, now we are going to discuss in a step-by-step fashion according to the plan of the class. So as we have planned earlier, that first we are going to discuss the important one-liner, okay, single liner question that has been asked in INI-CET. Okay, so try to answer. So I believe all of you know the answer of the first question, that is here, that in negative feedback feedback gain is infinity in which organ system control? So, all of you know the answer of this question is kidney. Okay. So, whenever kidney control your blood volume, okay, blood volume, or if the kidney is controlling your blood pressure, or the kidney if it is controlling your blood pressure, this kind of control system gain has infinity, because all of you know that the gain is correction upon error, that we will discuss later on also. Okay. So, considering the correction upon error in case of kidney, whenever the kidney is controlling your blood pressure or blood volume, the error, the residual error is absolutely 0. So, that is why the ratio between correction upon error is infinity. That is why we say that the gain is infinity in case of one organ system control, that is the kidney, which is controlling your blood volume and BP, right. Second question, Gibbs-Donan equilibrium is mainly by. So, the bottom line is that the Gibbs-Donan equilibrium is because of the presence of large non-permeant ion on one side of the compartment. Suppose two compartments are divided by a semi-permeable membrane. So, the Gibbs-Donan equilibrium will be due to the presence of large, okay, impermeant ion on one side of the compartment, and I absolutely correct. The protein was the answer in the question that has previously been asked, right. So, the protein is a large impermeable or impermeant ion through the semi-permeable membrane. Otherwise, the sodium, potassium they can easily transport from one part of the other part of the membrane. They are not going to maintain the Gibbs-Donan equilibrium. The Gibbs-Donan equilibrium will be seen only because of the presence of the large impermeant ion or impermeable ion on one half of the compartment, right. Third thing, potential developed due to free movement of diffusible ion. So, here you have to be little bit careful. If the question says potential developed due to free movement of multiple diffusible ions, right. So, then the answer will be a little different. So, whenever a single type of ion is diffusing through cell membrane, there will be generation of a diffusion potential, and that diffusion potential is calculated by which equation? You all know, that is the Nernst equation. Okay, Nernst equation. So, Nernst equation calculate the diffusion potential of a single type of ion when it is moving through the cell membrane. And all of you, I believe, remember that in resting condition, cell membrane is most permeable to which ion? Potassium ion, because of the presence of maximum number of potassium leak channel, right. So, do not forget that thing. But you know that whenever multiple ions are diffusing through a cell membrane, multiple ions are diffusing through cell membrane, then the diffusion potentials which will be created because of this multiple ion is basically your resting membrane potential of the cell, and the calculation of the resting membrane potential is done by which equation? Very good, GHK equation, that is the GHK Goldman-Hodgkin-Kaj constant field equation, right. So, this equation name you should remember. Okay, Goldman-Hodgkin-Kaj constant field equation, right. So, you in the MCQ you can get this Goldman equation or Goldman-Hodgkin-Kaj equation as an option, or may you also get a constant field equation, both can be the answer. So, you have to remember the whole name, GHK constant field equation, that is the equation which is used to calculate the resting membrane potential of most of the cells in our body, because in you know that biological cells is permeable to not only potassium, it is also permeable to chloride, it is also permeable to sodium a little bit in resting condition. So, that is why some of you have written that potassium is maximum permeable, followed by chloride, followed by sodium, right. And because the three ions are diffusing through cell membrane, you cannot calculate the RMP by Nernst equation. RMP can be calculated by Goldman-Hodgkin-Kaj equation, and when single ion is diffusing through cell membrane, then Nernst equation can be used to calculate, right. Okay. Now, feed forward control system, there are multiple examples of the feed forward control system, yes, but whatever you have to remember that recently they have asked you that vasoconstriction in response to exposure to cold environment. So, whenever you expose to cold environment, your body temperature decreases, but what about your core temperature? Core temperature does not decrease yet, but to protect the core temperature, what will happen? The hypothalamus will send signal, and that will rise the core body temperature even before the fall. So, what is happening? You are exposed to cold environment, your skin temperature is down, but still your core body temperature is not down. So, what the body is doing? Body is taking some anticipatory measurement, anticipatory precautions, which is raising the core body temperature ahead of the fall of the core body temperature. So that's why the vasoconstriction is happening to maintain the core body temperature, because that is the most important temperature. So that's why we say that thermoregulation, okay, thermoregulation has feedback system also as well as feed forward, okay, thermoregulation, feed forward and feedback, both are there. So the question that has been asked previously is the vasoconstriction in response to cold environment, in cold environment, right. So this is an exam, this is a question that has been asked already. So please try to remember feed forward control system. Apart from that, yes, very good, that apart from this, the feed forward control system has what is happening, feed forward control system has many other examples, right. I believe that you remember all of them, like there was one question that increase in the heart rate even before the start of the exercise, increase in heart rate or increase in respiratory rate even before, even before the start of exercise, even before start of exercise. This is a question which has been asked already, okay. So this is due to psychic stimulation, feed forward control system. So this is a kind of feed forward control system. This is due to psychic stimulation. So your brain is giving stimulus to the heart, your brain is giving stimulus to the respiratory system, that the person is going to start the exercise, okay. If I ask you start exercise, what will you do? You will think that sir ने बोला है मेरे को exercise करना है, so I have to start the exercise. So thinking of this scenario will leads to increase your heart rate, increase your respiratory rate, and that is known as the feed forward anticipatory control system. Apart from that, you have already mentioned here cephalic phase of gastric secretion and the receptive relaxation of the stomach. Those are also feed forward control system. And in cerebellum, there is a system, there is an loop where the feed forward control system is also there, that is granular cell followed by basket cell followed by Purkinje cell. So that circuit is also part of the feed forward control system, okay. So please remember this, okay. So this is one liner first slide. Next one. Highest frequency of BER is seen in. If no option is given, what will be the answer of this question? What will be the answer of this question, everybody? If no answer, suppose no option is given, okay. Yes, it will be duodenum, 12. Duodenum followed by jejunum, okay. In the question that has been already asked, duodenum was not there on the option, that's why you marked jejunum. But if the duodenum is there, that has the highest frequency, duodenum, jejunum followed by, okay, ileum. So that sequence I will also show along with the number that I have kept. This BER number is very, very important. I have kept it in the numerical section, okay. So this number you have to remember, what is the frequency of BER in case of duodenum, that is 12. In case of jejunum, what is the frequency followed by ileum. So this sequence you have to remember, because you don't know what is the options given in the questions, okay. So duodenum followed by ileum, okay. And lowest frequency cecum is there, but if the cecum is not in the option, then stomach will be the lowest frequency, that I will discuss a little later, okay. Now the slow waves. So now here you everybody note down either the question can be given in the form of BER or the question can be given in the form of slow waves, both are same, okay. So BER is the full form is the basic electrical rhythm or basal electrical rhythm. Same thing is the slow wave in the GIT, slow wave. So what is slow wave? Basically this is BER, basal electrical rhythm. What is that? That is nothing but the fluctuation of the resting membrane potential of the smooth muscle of the GIT, like this. So the fluctuation of the membrane voltage is happening in a slow manner. That's why the wave, this waveform is known as a slow wave or BER, right. Now you can easily answer that the slow wave or the BER is generated by interstitial cells of Cajals, okay. Interstitial cells of Cajals or Cajals, whatever you say, that is the answer of this question, okay. Now the next one is the migratory motor complex. Next one is the migratory motor complex. Silent. Right. So migratory motor complex is important for INI-CET as well as NEET PG, very, very important. Yes. So 90 minutes, MO cell very good, motilin, everything you have talked about the migratory motor complex. So it appear at an interval of 90 to 120 minutes, right? So Deglina, what is there in the option? 90 minutes is the best choice. If not, 120 minutes can be marked. And migratory motor complex is a fasting motility. So this is the most important thing that you have to remember. Okay, because sometimes option will be given like that the in presence of feeding the vagus control the migratory motor complex. So that will be false statement, because feeding means migratory motor complex will be abolished, right? So it's a fasting motility, it's an housekeeping motility, and it starts whenever you have fasted for the last 90 minutes. So migratory motor complex starts in an empty stomach. The stomach should be emptied for at least 90 minutes. So that's why 290 minutes are important. One is the interval between two migratory motor complex is also 90 minutes, 90 to 120 minutes, and migratory motor complex start or appear after 90 minutes of empty stomach. These are the two things you have to remember. Next thing you have to remember that for migratory motor complex starting, initiation and regulation, it does not require the nervous system. It requires only one hormone, that is the motilin. So motilin acting on the entering nervous system is controlling the migratory motor complex. You do not require the sympathetic or parasympathetic which is controlling the gut. You do not require them. Even if you cut them, the migratory motor complex will appear whenever the presence of motilin hormone there in the smooth muscles of GIT. That you have to remember, okay? That is the speed you are talking about. So very good. So I believe your preparation is going on in the correct direction. At least you have read the last 3 to 5 years questions and they are on your fingertip. Very good. Okay. Now highest concentration of the potassium is seen in. So you know this question has been asked in I think few years back in 2018 or 19, and the answer was the colorectal fluid. Okay. So colon or rectal fluid, colon or rectum fluid. So whenever the question is about the concentration of the potassium, then it is the colorectum. But if the question is about the total amount of potassium secreted, secreted per day, then in these cases the saliva will be the answer. Saliva will be the answer. So salivary secretion volume is much more than that of the colonic volume. That's why if you calculate the total amount of potassium secreted by GIT, then the highest amount of potassium is secreted by the salivary secretion. Okay. So these are the two important things that you have to remember. Next page. Now tell me the answer of first one. Resting membrane potential of cardiac muscles. Okay. So cardiac muscle means atrium and ventricular muscle. Very good, very good. So this is minus 90 millivolt. Okay, and parallelly you remember minus 80 millivolt is for Purkinje fiber. Purkinje fiber, right? And whenever you are remembering this, please don't make confusion that nodal tissue. Okay, nodal tissue has a different RMP. Okay, nodal tissue like SA node minus 50 and AV node minus 60. So generally we say minus 65 to minus 40 millivolt. This is the range for nodal tissue resting membrane potential. So you have to remember all of them. Okay, so nodal tissue from minus 65 millivolt to minus 40 millivolt. For cardiac muscle like atrium and ventricular muscle minus 90 millivolt, for Purkinje fiber minus 80 millivolt, and obviously you remember that the nerve fiber has a different RMP, nerve fiber has minus 70 millivolt, right. So these are the number that you have to remember. Okay. Now normal AV nodal delay. Okay. So three things, one thing from SA node to AV node, then AV nodal transmission, and from AV node to bundle of His. So normal AV nodal delay is the highest among all these three, that is 100 millisecond. Yes, there is a range, but at least you have to remember that is a 100 millisecond is the normal AV nodal delay. Okay. Then electromechanical systole. This question has been asked few years ago. Electromechanical systole, what is the meaning of this? Means इलेक्ट्रिकल एंड मैकेनिकल दोनों में से could you tell me which event occur first? Suppose heart of contraction of the heart you are thinking. So first of all you require the electrical event or contraction will start before the electrical event. Obviously electrical event is required. Electrical event means action potential. Action potential is nothing but summated action potential is nothing but the ECG. So, whenever there is starting of the Q wave in the ECG, that is the beginning point of the electromechanical systole. So, one electromechanical systole, you have to note down what is the starting point of the electromechanical systole and what is the ending point of the electromechanical systole. So, ending point means systole means heart is contracting. Contraction will end whenever there is closure of the semilunar valves, because that is the point where whenever the closure of the semilunar valve is happening, then what will happen? The ventricle will start relaxation, because that is the end of contraction. Contraction means what the heart is doing? It is ejecting the blood. Whenever the ejection is complete, the semilunar valve will close, and closure of the semilunar valve will produce which heart sound? S2, second heart sound. So, that is why we say that QS2 starting from the Q wave in the ECG up to the second heart sound, that is the duration. This duration is known as the electromechanical systole duration. Very, very good. Electromechanical systole duration. Okay, you have to remember this. Okay. Now, the next question, main site of total peripheral resistance, total vascular resistance or peripheral vascular resistance. Whether it is systemic vascular resistance or the peripheral vascular resistance, answer is same, that is nothing but the arterioles. Arterioles, right? So, arterioles are the vessels where the resistance is maximum. Okay. So, arterioles are known as the vessels of resistance, peripheral vascular resistance or systemic vascular resistance. Okay. And the next question, which one is hypoxia you are saying? Now, carotid baroreceptor. So, baroreceptor, they are not sensitive to hypoxia. No? That is chemoreceptor which is sensitive to hypoxia. Okay. Hypercapnia, hypoxia. So, here is a baroreceptor. Baroreceptor means it is a pressure sensor receptor, it is a mechanoreceptor, it is a pressure sensor receptor, it is a mechanoreceptor. So, clearly it is written in Gedong that it is the pulse pressure followed by mean arterial pressure. So, baroreceptor whether it is carotid body और aortic arch दोनों जगह पे होता है. पहला क्वेश्चन समझ के रखो कि सपोज द क्वेश्चन इज which baroreceptor is most sensitive, carotid body baroreceptor or aortic arch baroreceptor or aortic arch baroreceptor? Which baroreceptor is more sensitive? Could you tell me the answer of this? Which one is more sensitive, carotid body or aortic arch baroreceptor? Carotid body baroreceptor is more sensitive, right? Now, if I ask you that whether it is carotid body or aortic arch, baroreceptor as a whole more sensitive to which blood pressure? Pulse pressure followed by mean arterial pressure. Okay. So, please remember pulse pressure is the answer of this question followed by mean arterial pressure. Okay. That is all. Next question, reflex responsible for tachycardia in right atrial distension. Very, very important question. Multiple times this has been asked in different format. Okay. And followed by this Bowditch and Andreff effect. Very, very important. Not basal. बेजोल जेरिस का जो रिसेप्टर होता है वो हमारा होता है लेफ्ट साइड ऑफ द हार्ट में. ओके, लेफ्ट वेंट्रिकल में, सेप्टल वॉल पे. ओके, सो हियर योर आंसर विल बी BBB. ओके, बेन बेज रिफ्लेक्स. ओके, सो make it one thing clear. So, whenever there is right atrial distension, okay, three things will happen. There will be activation of the Benn-Beige reflex, because of which there will be increase in heart rate. Apart from that, right atrial distension due to any cause, suppose there is congestion of the right atrium, okay, or suppose there is increased blood volume. So, right atrium will get more blood, there will be distension of the right atrium. Whenever there is distension or stretching of the right atrium, there will be increased secretion of atrial natriuretic peptide, which is going to control your excess volume. Apart from that, there will be decreased secretion of ADH. Okay, that is the reason, but the thing is that whenever the right atrium is stretched, the Benn-Beige reflex will be activated, which will increase the heart rate through the inhibition of the parasympathetic and stimulation of the sympathetic system. So, increased heart rate will be there. Apart from that, there will be increased secretion of atrial natriuretic peptide from the muscles of the right atrium, and there will be decreased secretion of the ADH hormone. This thing you have to remember. So, from the right atrium there is a vagus nerve which will go to the level of the hypothalamus, and it will inhibit the secretion of the ADH. So, ultimately you are understanding that ADH secretion should be lower because your volume is high, that is why the right atrium is stretched. So, if the blood volume is high, if the body has understood that the right atrium is stretched because of the increased blood volume, so what you will, how can you get rid of excess volume or excess blood? So, your water reabsorption should be decreased. So, that is why there should be decrease in the ADH secretion, and ANP atrial natriuretic peptide, more sodium excretion should be there so that the volume can be controlled. So, this way these three things is happening when the right atrium distension is there. Now, Bainbridge reflex is causing tachycardia. This is the main response. It does not alter the contractility of the heart so much. But you know, apart from this right atrium Bainbridge reflex, parallelly there is a basal-gyrus reflex, where the receptor is located on the left side of the heart and left ventricle, not the left atrium, left ventricular muscle as well as septum of the interventricular septum. Okay. And whenever the basal-gyrus reflex is activated, what is the triad I told you in the class? That there will be decrease in heart rate, bradycardia, there will be decrease in blood pressure, severe hypotension. Along with that, there will be coronary vasodilation. Apart from coronary vasodilation, there will be apnea followed by hyperventilation. So, these are the things that you have to remember about basal-gyrus reflex at least. Okay. And basal-gyrus reflex, I am telling you, for INI-CET it is very, very important, because previously it has been asked basal-gyrus reflex is activated by which chemicals. So, could you recall serotonin, veratridine, capsaicins, phenyl biguanide? Those are the chemicals which activate the basal-gyrus reflex on the left side of the ventricle, right. So, basal-gyrus reflex is the left side of the ventricle and Bainbridge reflex is the right atrium, right. So, don't forget this. Receptor कहाँ पे होता है ये भी क्वेश्चन में दिया जा सकता है, एंड रेस्पॉन्स में basal-gyrus reflex में हाइपोटेंशन होता है, ब्रेडिकार्डिया होता है, Bainbridge reflex means tachycardia will be there. Okay, okay. Now, next one is Enrol effect and Bowditch effect. Okay. So, this thing, Enrol effect is increase after load. Increase after load increases the contractility of the ventricle. That is known as Enrol effect. Bowditch effect is increase heart rate can also increases the contractility of the heart, and last one is increase end diastolic volume can also increase the contractility of the heart, and that is known as the Frank-Starling law. So, I remember like this three things in a single one. Okay. So, contractility is the main thing here, increase in contractility of the heart, increase in contractility in presence of increase after load, that is Enrol, increase contractility in presence of increased heart rate, that is Bowditch, increase contractility in presence of increased end diastolic volume, which is also known as the preload, is known as the Frank-Starling law. Okay. So, this end diastolic volume is also known as the preload. Okay. Best index of preload is end diastolic volume, and best index of afterload is your mean arterial pressure, which is determined by TPR, total peripheral resistance. So, two things, preload, the best index of preload is end diastolic volume or end diastolic pressure, but end diastolic volume or end diastolic pressure is determined by venous return. So, venous return is a determinant of preload, which is nothing but the end diastolic volume. So, if the question is which one is the best index of preload, you have to mark end diastolic volume even if the venous return is given, because venous return is the determinant, that is not the index. right? Same way, whenever the question is what is the best index of afterload, it is the aortic pressure, mean aortic pressure. But mean aortic pressure in terms determined by total peripheral resistance. So, if the MAP is not given in the choices, then TRP can be an answer. But if the question is best index of afterload and both are the given in the option, then mean aortic pressure will be the single best answer. Okay. So, this you have to remember in a in your fingertips, so that you should not mistake this any of this information. Okay. Next one, glucose transporter present on the apical membrane of the PCT, apical membrane of the PCT. Bolo answer. Everybody answer this question. Glucose transporter present on the apical membrane of PCT. SGLT बोलने से नहीं होगा, 1 और 2, SGLT 1 और SGLT 2, SGLT 2, right? But if I just change this word apical, suppose I have changed this word apical to basolateral, basolateral. Now what will be the answer? Same, basolateral PCT. अब क्या आंसर होगा? Same thing, every sentence is same, only I have changed the apical to basolateral. Now I want to see which glute. Very good, very good. So that is glute 2. Very good. Okay. So SGLT 2 is the apical membrane and basolateral membrane is the glute 2. And with the help of this transporter, how much glucose is reabsorbed in the proximal convoluted tubules? 90%. And remaining 10% of glucose is reabsorbed in the later half of the PCT, which is known as the PST. PST stands for proximal straight tubule, which is a late part of the proximal tubule, which is known as the proximal straight tubules. Okay. So, proximal straight tubule contain the glucose transporter, which is SGLT1. So, that is why we say that SGLT1 is also present, SGLT2 is also present in the kidney for glucose transport in the apical membrane. But the major glucose is transported by SGLT2, and that is why SGLT2 inhibitor are used for treatment of the diabetes mellitus, you know, okay, but not the SGLT1 inhibitor. So, SGLT1 is present in the later half of the proximal tubules, and that is known as the proximal straight tubule, which is responsible for 10% of the glucose reabsorption. Okay. Yes, yes. So, I forgot to mention that if it is SGLT1, so it will be coupled with GLUT1 in the basolateral membrane. So, this is very simple. If it is SGLT2, then it will be coupled with GLUT2. If it is SGLT1, coupled with GLUT1. Okay. And which is the main one? SGLT2. Okay. Now, I believe you all remember that SGLT2 and GLUT, which one is the facilitated diffusion or which one is the secondary active transporter? ये दोनों में से. Suppose the question is glucose transport by the apical membrane of the PCT is which kind of transport? Secondary active, primary active, facilitated diffusion. What will be the answer? इसका आंसर बताओ पहले. Glucose transport from the proximal part from the apical membrane of the PCT is by which process? Primary active, secondary active, facilitated diffusion. What will be the answer? Secondary active transport. Very good, because SGLT, they are the secondary active transport and GLUT is the facilitated diffusion. Very good, all of you know this thing. Now next question, third का answer बताओ. Very good. Third का answer बताओ. In the late part of the PCT, luminal concentration increases for which one? Chloride will be the answer, because you know the proximal part में, in the proximal part sodium reabsorption happens with amino acid, with bicarbonate, with citrate, with phosphate, everything. So what happens? The chloride remains in the first part. So that's why in the later half of the PCT, the chloride concentration increases a little bit. This question also has been asked in previous year question, so try to remember. Now, next one is a little bit controversial, but it should not be any controversy because macula densa are the cells of the uppermost part of thick ascending limb of loop of Henle. Okay. So, TAL, thick ascending limb of loop of Henle, macula densa is present in the uppermost part of the TAL. But if this is not given, then your answer will be that TAL, thick ascending limb of loop of Henle, and DCT junction. Okay. But there was an MCQ where TAL was not in the option, junction भी नहीं था and TAL भी option में नहीं था. In that cases you have to mark DCT, but DCT is not the answer of the macula densa. Macula densa cells are the cells of the thick ascending limb of the loop of Henle. If you have to choose a single best answer, it is the cells of the uppermost part of the TAL, because you know the macula densa cell contains one transporter. That transporter is NKCC, sodium potassium 2 chloride transporter. Now, could you tell me NKCC is present in which part of the nephron? From your pharmacology knowledge, you know that this is present in the TAL. So, that is why you know that whenever scientists isolated this macula densa cell, they found out that the apical membrane of the macula densa cell contains a transporter which is NKCC, and then they came to know that it is not the DCT cells, it is the uppermost part of the TAL. Basically, it is a junction between TAL and DCT, which is the macula densa cell. Okay. Now, next question, erythropoietin or erythropoietin, whatever you say. Erythropoietin acts on which cell stage in RBC development? That was the question. So, answer of this question will be CFU, E, not the B, colony forming unit, erythroblast. Okay. So, I will tell you that erythropoietin act on colony forming unit. It can act on the burst forming unit also. Okay. It can act on the pro-normoblast also. It can act on the early normoblast also, as well as intermediate normoblast also. Okay. So, all of this cell stage can be stimulated by erythropoietin, but maximum stimulation by erythropoietin on which cell? Colony forming unit, erythroblast, because this cell contain maximum erythropoietin receptor. That is why the main effect is on CFU-E, colony forming unit, erythroblast. Okay. Now, there was another questions from this erythropoietin, that where from it is secreted. Now, you know the answer of that it is secreted from, obviously you know the answer, kidney, and it is also secreted from liver. Mostly it is from kidney, okay, but it can also secreted from liver. Yes. So, from kidney there is a cell which is known as the peritubular capillary cells. ये तो भूलना ही नहीं है. Along with that, there is another cell which is known as a Noor cell. Okay, these are the two cells which secretes the erythropoietin in kidney. Okay, and in liver, that is the perisinusoidal. Okay, perivenous or perisinusoidal hepatocyte. Okay, so these are the cell that is going to secrete the erythropoietin. So, this NOR cell, NOR cell, I told you in the last class also in RR Ignite or something like that. So, peritubular capillary epithelium, it was there already. Now, NOR cell has been added. So, try to remember both of them. Okay, both are the cells which are secreting the erythropoietin in kidney, and in liver, perivenous hepatocyte or perisinusoidal hepatocyte is the answer of the erythropoietin secretion. Next one, maximum airflow resistance is seen in which part of the respiratory system? So, starting from your nose up to the level of the alveoli, if I ask you maximum resistance to airflow will be seen in which part? Okay. Yes. So, it is the medium to large bronchi. Okay, very good, medium to large bronchi. Okay, it is not the smaller, medium to large bronchi, which are lobar and segmental bronchi, lobar and segmental bronchi. Okay, and if you say in terms of division, division number 3 to 5, very good, division number 3 to 5 according to the Oebel's classification, that you know starting from the trachea, which is 0 division, then major bronchus, they are the division number 1. If you go in this fashion, then division number 3 to 5 is the area where the resistance to airflow is maximum, and that division number 3 to 5 is which segment in terms of anatomy, that is the lower or segmental bronchi, or you can say medium to large size bronchi. Okay, so these are the things. Now, ventilation perfusion ratio is maximum at. So, be careful a little bit, although it is a very easy question, but sometimes question can be given like this, that the ventilation in the lung is maximum. Ventilation of lung is maximum in which part, and perfusion of lung is maximum at which part. Perfusion of lung is maximum at which part. So, obviously, the answer of the ventilation perfusion ratio, answer is apex. Answer is apex, and ratio is around 3.3 is the ratio. But if the question is there asking simple ventilation is maximum in which zone of the lung, your answer is base of the lung. Perfusion is maximum in which zone of the lung, that is also base of the lung. So, base greater than apex is the answer of both this question. Base greater than apex is the answer of both this question, but whenever they are asking ratio, ratio is maximum at the apex of the lung. Okay. Now, next one is the rhythmic respiration is maintained by. So, rhythmic respiration is maintained by a pacemaker of the respiration, pacemaker of respiration. This has been asked in INI-CET multiple times, and that pacemaker of respiration is known as the, yes, very good, pre-Bodzinger, pre-Bodzinger complex of neuron. Pre-Bodzinger complex of neuron is a part of, it is a part of VRG, ventral respiratory group of neuron. Okay. So, these are the basic minimum thing that you have to remember. Next one, anatomical dead space is calculated by. So, answer of this question is single breathe nitrogen wash out method. Single breathe nitrogen wash out method, which is also known as the Fowler's method, very good. Okay. Now, here you remember the pre-Bodzinger complex, it is located at the level of the medulla, not at the level of the pons. Pons में जो दो सेंटर होता है, that is the pneumotaxic and amniotic center. They control the regulation depth and rate of the respiration, not the rhythm. Rhythm means that is the rhythm of respiration, that is the pacemaker, that is located in the medulla. Okay, and that is name is pre-Bodzinger complex. Okay. Next one, easy one. Damage to the pituitary stalk during surgery. So, all of you know that from hypothalamus, the pituitary, the anterior pituitary is connected mainly, and most of the control from hypothalamus to pituitary is stimulatory, but for prolactin, the control from hypothalamus is inhibitory by the dopamine, which is known as a prolactin inhibitory factor. So, that is why whenever you cut the stalk, the inhibition from the hypothalamus will be lost, and because of which the prolactin level will be increased. Okay. Now, hormone which are under the inhibitory control of hypothalamus. So, obviously, the previous one is the answer of this question, the prolactin is the answer, but apart from prolactin is also there, as well as growth hormone. Yes, very good, because growth hormone, you know, normally it is mainly under the positive control from hypothalamus. Okay, growth hormone releasing hormone बोल के positive control होता है, but also there is somatostatin. Somatostatin from hypothalamus inhibit the growth hormone secretion. So, that is why the major inhibitory control from hypothalamus is on prolactin, but obviously for growth hormone also there is a little bit inhibition. So, this question which was asked in INI-CET, both the option are there, prolactin and growth hormone both are in the option. So, you have to choose growth hormone and prolactin both, right. Which hormone has permissive role in puberty? Now, you all know the answer of this question, leptin is the answer, and leptin का बहुत बार question आया है. So, please try to collect as much as possible information from leptin, which pathway is activated by leptin, okay, leptin कहाँ से secrete होता है, leptin level fat level के साथ क्या relations है. So, those information should be there on your fingertip. Okay. Next one. Neurotransmitter released by inner hair cell during depolarization. Answer batao. Yes, Jack stress pathway. Okay. Neurotransmitter released by inner hair cells during depolarization. Very good. Okay. So this is glutamate. Okay, glutamate is the neurotransmitter of the inner hair cell. Endocochlear potential is positive or negative? Positive, plus 80 to plus 85 millivolt. No, endocochlear potential is the potential inside the scala media. Okay, scala media composition is like that of the ICF. ICF means it is huge amount of potassium it contains. Because of the huge amount of potassium, the potential is positive. That's why the endocochlear potential is positive. Okay, plus 80 to plus 85 millivolt is the endocochlear potential. So endocochlear potential is the potential within the scala media. Okay, scala media composition like that of the ICF, right? And it contains huge amount of potassium because of the secretion of potassium from stria. Okay, so all of you know that thing. Okay, because of that the positive potential is there, plus 80 or plus 85 millivolt. Okay, sensation detected by Pacinian corpuscle. So Pacinian corpuscle is the most rapidly adapting touch receptor, and the best stimulus for Pacinian corpuscle is the vibration sense as well as deep pressure. Very good, deep pressure. Very good, vibrations and the deep pressure. These two things you have to remember. Okay. Discriminative touch sensation identified by. There is another image from this, I will tell you. So discrimination between 2 points, discriminative touch. The answer will be Merkel's. Yes, very good, Dr. Isha. You remember many things. Okay. Merkel's को follow करो. I will show you the reference also in today's class. I have kept that. Okay. There is image section that is there. Merkel's follow करो. क्यों मैं बताऊंगा आपको. ठीक है ना. Discrimination between 2 points, 2-point discrimination or reading of the braille. All of this answer is the best answer is the Merkel's, not the Meissner one. Meissner is there, but best is the Merkel's. Okay. Now without external cues, so we know that the sleep wake cycle is a kind of circadian rhythm. Okay, sleep wake cycle is a kind of circadian rhythm. Okay, circadian rhythm maintain a 24-hour cyclicity, but this 24-hour cyclicity is maintained because of the presence of the nucleus, which is known as the suprachiasmatic nucleus. Okay, now if that suprachiasmatic nucleus is destroyed, or if the light and dark, this kind of stimulus is not there, that's why the question is without external cues, that is the light. So if the light dark cues is not there, if the suprachiasmatic nucleus is destroyed, then this sleep wake cycle, which was maintaining a circadian rhythm, this circadian rhythm will be disturbed, and in that cases the circadian rhythm, which has a duration of 24 hours, this duration will be increased 24.15 hours. So you have to remember that the duration of the sleep wake cycle in this condition will be increased greater than 24 hours. Okay, 24.15 hours, that is the exact answer. But this question was asked few years ago in INI-CET that if the external cues is removed, then what will happen to the duration of the sleep wake cycle in a person? Or suppose suprachiasmatic nucleus is destroyed, what will happen to the sleep wake cycle duration? It will be more than 24 hours, right? So SCN is maintaining the sleep wake cycle to exactly 24-hour duration. If that nucleus is destroyed, or if the input to that nucleus is not there, like light and dark, then it will be more than 24 hours. Okay, fine. Next one, Golgi tendon organ senses. Which thing? That is the tension. Tension of muscle tendon. So tension of the muscle tendon is detected by Golgi tendon organ. Yes, very good. So Golgi tendon organ is innervated by 1B type of fiber. It detects the tension, and muscle spindle detect the length of the muscle as well as velocity of the muscle. So muscle spindle detected it detects the length of the muscle and velocity of the muscle. This question has been asked 2 to 3 times, that muscle spindle detect which one? One only length, only velocity, both length and velocity. So this question can be given. Good evening. Very good. Thank you. Now, in skeletal muscle, DHPR and RYR receptor are coupled by. Recently, this question has been asked in INI-CET. DHPR, RYR in skeletal muscle, skeletal muscle, skeletal muscle. So, it is a kind of mechanical. So, mechanical coupling, or if this is their electromechanical coupling, then it will be best. Okay. So, electromechanical coupling, and I told you repeatedly that if it is cardiac muscle, then what will be the answer? Cardiac muscle will be the answer will be electrochemical calcium mediated coupling, and if it is smooth muscle, pharmacomechanical coupling, pharmacomechanical coupling. So, just remember this 3 word. Okay. For skeletal muscle, mechanical; for cardiac muscle, chemical; for smooth muscle, pharmacomechanical coupling. These 3 word you remember. Okay. Now, again this is an old question, Rensa cell inhibition. So, previously we were discussing that in cerebellum, which kind of circuit is there from granular cell to basket cells to Purkinje cell, which type of circuit that was, we have discussed previously. In cerebellum, if the circuit is from granular cell to basket cells to Purkinje cell, what kind of circuit that is? Feed forward circuit. Okay. Feedback circuit is also there in cerebellum, but whenever the question is that in case of cerebellum, the granular cell followed by basket followed by Purkinje, ये कौन सा टाइप ऑफ सर्किट? ये हमारा फीड फॉरवर्ड सर्किट था, फीड फॉरवर्ड. ओके. Now, another thing you have to remember that the Rensa cell inhibition, this is a kind of inhibition which happens at the level of the spinal cord. Motor neuron, alpha motor neuron has a self feedback system. So, this Rensa cell inhibition is a kind of feedback inhibition, which is also known as recurrent inhibition. So, feedback inhibition or recurrent inhibition. Glycine is the neurotransmitter. Okay, glycine is the neurotransmitter in that cell. Okay, Rensa cell basically जो interneuron होगा, that Rensa cell will contain glycine neurotransmitter. Okay, so Rensa cell is a kind of cell which is present at the level of the spinal cord, alpha motor neuron को inhibit करने के लिए, and this kind of inhibition is a feedback inhibition which is also known as a recurrent inhibition. ठीक है. During muscle contraction, detachment of myosin head from actin. Important question. Sometimes silly mistake can happen. So, remember that attachment does not require ATP. Attachment require only calcium. So, whenever calcium is there, attachment will be there. ATP is not required for the attachment process per se. But adenosine triphosphate is required for detachment of the myosin head from actin to maintain the cross bridge cycling. So, cross bridge cycling will be maintained if the ATP is present, because attachment will be done by calcium, detachment will be done by ATP. But whenever ATP is deficient, like for example, what happens after death, rigor mortis, the detachment is not going to happen, and that's why muscle will be rigid. Getting my point? So, detachment require adenosine triphosphate. That's why if there is deficiency of the adenosine triphosphate, which generally happens after death, the muscles will be stiff, persistent contracted state for some times, and that is rigor mortis. So, ATP is required for detachment. Okay. Now, the next question, physiological mechanism behind TENS, transcutaneous electrical nerve stimulation. So, not only transcutaneous electrical nerve stimulation, if the question is that massaging or acupuncture reduces pain sensation, by which mechanism? Your answer will be by acting at the level of the gate. So, gate control theory mechanism, or you can say by closure of the gate. Yes, but absolutely true. So, gate control theory is main mechanism, by the acupuncture, by massaging. So if there is a pain in this area, so you give a massage towards this painful area. So what will happen? Your pain will be reduced. We know that thing. How it is happening? It is basically acting at the level of the spinal cord. So whenever you are giving massaging or acupuncture, it is activating A beta fiber, touch fiber, and that touch fiber inhibit the pain fiber, and that is happening at the level of the spinal cord. That is gate control theory. But the another theory is also saying that this fiber also goes to the level of the upper part of the brain, particularly the periaqueductal gray matter region. From the periaqueductal gray matter region, it releases certain neurotransmitter like endogenous opioids like serotonin. Those are also responsible for decrease of pain in case of this strains or acupuncture or massaging. So apart from this, you have to remember that endogenous opioids, okay, serotonin. So these are the neurotransmitters which are also responsible for decrease in pain sensation. Okay. So periaqueductal gray matter, all of you know, that is a path, that is the nucleus which is main for the descending pain inhibitory pathway. So that you have to remember. Okay. So I believe all of your preparation is going on in the right direction, because looking at the chat box, I can understand that all this thing you have understood and you have kept in your fingertip. Very good. Now we are coming to the mathematical problems. Okay. So mathematical problems which are generally given in INI-CET or typical INI-CET type of mathematical problems. So first question, answer batao. It will take a time. Yes, I am Bengali. लगता नहीं मेरा हिंदी देख के, हिंदी देखो इंग्लिश देखो पता लग जाएगा तुम्हारा. So देखो, so alveolar ventilation. So there is something called pulmonary ventilation or minute ventilation. So if the question is pulmonary ventilation in this question, then what I will do, I will multiply this 500 multiplied by 20. That means it is basically the tidal volume multiplied by respiratory rate. That is a pulmonary ventilation, which is also known as a minute ventilation. But here the question is about the alveolar ventilation. So alveolar ventilation, the formula is very simple. Alveolar ventilation means the air which you are breathing in, all that air is not reaching at the level of alveoli, because some of the air will be trapped in the dead zone, dead space air. Okay, so that's why alveolar ventilation means whatever tidal volume you are taking, from that you have to subtract the dead space volume, and then if you multiply this with respiratory rate, because we calculate this ventilation, whether it is alveolar ventilation or pulmonary ventilation, per minute. So that's why, so whenever you are calculating per minute, you have to multiply with the respiratory rate. So this is 500 minus 150 is given, that is normal, multiplied by 20. So it will be, I think, 7000 ml per minute, means 7 liter per minute is the okay. So this is the alveolar ventilation, because the respiratory rate is very, very high. So that's why here it is 7 liter. So if it is pulmonary ventilation, it will be directly 10 liter will be the answer. Okay, directly 10 liter will be the answer, but here it will be, yes, 20 multiplied by 350, that is the 7 liter. Got it, everybody? So this kind of simple mathematics generally is given in INI-CET, but you just have to know what is the formula to put into. Okay, that is the thing you have to remember. Sometimes pulmonary ventilation can be given, sometimes alveolar ventilation can be given, and all this information will be there, but you have to choose that which information you require in this question, which information you do not. Okay. Next question, calculation of the oxygen carrying capacity. Okay. So this was a question which was asked in previous AIMS exam. Okay. So here you remember one important information from your MBBS life, that 1 gram of hemoglobin can contain 1 gram of hemoglobin carry 1.34 ml oxygen. Yes. So 1 gram of hemoglobin carry 1.34 ml oxygen. Okay. So obviously here the 14 gram of hemoglobin is given. So 1.34 multiplied by 14. So this is basically 18.76 ml per deciliter of blood. This was the answer of the question. 19 was the answer given in the choices. So 19 will be the answer in this question. But one thing you remember, one extra thing. So whenever we are calculating oxygen carrying capacity of hemoglobin, okay, generally you know that 1 gram of hemoglobin can carry 1.39 ml of oxygen, not 1.34 but 1.39, but that hemoglobin should be pure hemoglobin, but you know, our hemoglobin is not pure, okay, because of the impurity in the air and impurity in your environment. What happens, the some part of the hemoglobin always in the form of the carboxyhemoglobin, methemoglobin. So that's why 100% pure hemoglobin is not there in your blood. That's why from this 1.39 we have derived that impure hemoglobin. Basically we should not say impure, but actual cases, real life scenario, 1 gram of hemoglobin can carry 1.34 ml of oxygen, okay. But if the question is asking that 1 gram of pure hemoglobin theoretically can carry how much amount of oxygen, then you have to multiply 1.39 multiplied by the hemoglobin, okay. Now whenever we are calculating this thing, we are assuming that hemoglobin is 100% saturated. Hemoglobin saturation normally is how much? 97, 98 to 100%. So 97% is the normal saturation of the arterial blood. So 97 to 100% मान के चलो. So whenever we are writing this information that 1 gram of hemoglobin can carry 1.34 ml of oxygen, we are assuming saturation is normal. We are assuming saturation is normal, that is 97 to 100%. But suppose a question has been given, in the same question, the same stem of the question is given, calculate the oxygen carrying capacity of hemoglobin if the hemoglobin of the person is 14 gram with a saturation of the arterial blood 70%, with a 70% of arterial blood saturation. Then how we are going to do? So whenever, okay, so if saturation of the arterial blood is given as 70%, then my calculation will be a little different. Then in that cases, what I am going to write, 1 gram of hemoglobin will carry 1.34 multiplied by 70 upon 100. This is the amount of oxygen. Because I told you that whenever we are assuming that 1.34, this 1.34 provided the saturation is 100%, but whenever the saturation is given, that saturation is now normal, lower saturation 70%, then 70 upon 100 multiplied by 1.34, and then if you calculate this from here, that 14 gram of hemoglobin will carry how much? So 14 gram of hemoglobin will carry 1.34 multiplied by 70 upon 100 multiplied by 14, simple like this, okay. So this way you have to be a little careful, okay. These questions look simple, but little careful whether they have given the saturation or not. In this question, single line has been given, saturation is not given. So we are assuming normal saturation, but if the saturation is given, you have to go one step extra, okay. That way remember this. I believe you all got it, okay. Now next question, calculate the compliance of the person. Lung compliance. Yes, hemoglobin calculation given, even compliance calculation was also given in INI-CET, okay. So compliance का जो formula all of you know, delta V upon delta P. Delta V means that is the volume change of lung, upon your pressure change. So whenever a person is taking, suppose my lung is in resting condition, now I am taking a normal breathing, tidal volume has entered in my lung, right. So how much volume has been changed? The amount of air which has entered in my lung, that is the volume change which is happening inside the lung. Getting my point? So tidal volume is the change of the lung volume during normal breathing. If you are taking a tidal volume of 700 ml, so how much expansion has occurred inside your lung? 700 ml in both the lung. And if the tidal volume is 500 ml, so how much volume change has happened inside the lung during normal breathing? 500 ml. So that's why in this cases, this tidal volume is equal to my delta V. And during normal breathing, we know that interpleural pressure changes from less negative to more negative direction. Normally minus 2.5 millimeter of mercury से लेकर minus 6 millimeter of mercury, that is a normal change of interpleural pressure during breathing. So during normal inspiration, interpleural pressure become more negative. That is we know all know. So in these cases, there has been given here that the interpleural pressure is becoming more negative. How much? From -4 to -9 millimeter centimeter of water. Sorry, not the millimeter of mercury, centimeter of water. So how much is the delta P or pressure change here? 5 centimeter of water, both in negative sign. So I am taking 4 minus 9, so that is 5. So now if you put into this formula, so compliance of the person, compliance of this lung will be equal to, very simple. So 500 ml is the volume change upon your 5 centimeter of water. So obviously this is 100 ml per centimeter of water. That means if you change 1 centimeter of water, there will be expansion of 100 ml of lung volume. Okay, compliance. Okay. Next one. This question can be given in terms of glomerular filtration pressure or capillary filtration pressure, and believe me, this question has been asked for the last 10 years. This question has been asked 4 to 5 times in different format. Okay, filtration pressure calculate karo, fluid inward jayega ki fluid outward jayega. So whenever you calculate this filtration pressure at the level of the capillary or at the level of the glomerulus, we take the helps of Stirling formula, Stirling law or Stirling filtration force, Stirling pressure. Okay. So filtration pressure is calculated by this one. What I am going to do, you can calculate easily. Okay, but again I am saying because after becoming a medico, your mathematical part of the brain become a little inactive. You know, there is a part of the brain which is dedicated for mathematics, so that part of the brain is a little bit depressed whenever you finished your 5 years of medical career and then internship. So इसलिए क्या होता है, even simple calculation can be missed in exam hall. Okay, so always try to use rough paper, try to jot down there, okay, and then try to go to the final answer. So here you have calculated rightly, very good. So capillary hydrostatic pressure, that is a 30 millimeter of mercury, that is pushing the fluid in the outward direction. So from capillary to outward direction. Then it is also given that tissue hydrostatic pressure is 2 millimeter of mercury. So this 2 is pushing the fluid in the opposite direction. And then what else is given? Capillary colloidal osmotic pressure. So 25 millimeter of mercury, it is drawing the fluid towards the capillary. It is drawing the fluid towards the capillary. Okay, so in this direction. And tissue oncotic pressure, that is 2 millimeter of mercury, that is drawing the fluid in the outward direction. So if I have to calculate the net filtration pressure from capillary towards the tissue, then the net force will be 30 minus 2 this, okay, plus 2 is minus 25. So 2 ये हो जाएगा 30 minus 25, that is 5 millimeter of mercury. Okay, so this way easily you can calculate the net filtration pressure at the level of the capillary or net filtration pressure at the level of the glomerular capillary. Okay, so glomerular capillary mein rather than this tissue, they will say that Bowman's capsule hydrostatic pressure, Bowman's capsule oncotic pressure. Otherwise the question will be same format. Or sometimes be careful, sometimes they will ask you question clearly that calculate the net filtration pressure towards the arteriolar end, towards the venous end. Question can also be given like this, arteriolar end towards the venous end. Okay, so in that cases be careful. Okay, if the questions is given that hydrostatic pressure towards the arteriolar end is 30 and towards the venous end is 29, then oncotic pressure towards here is 25, here is also 25. Hydrostatic tissue pressure here is, so different value will be given and they will say arterial end, venous end. That time you have to be extra careful if the question is calculate the net filtration pressure at the arterial end, or if the question is calculate the net pressure at the venous end, your answer will be different. Okay, so that way a little bit careful is required. ठीक है, blurring हो गया. Okay, next one. Calculate the interstitial fluid volume from the following data. Not a old question, but this kind of question has been asked, but this question is different. Okay. This kind of question has been asked in INI-CET, but this is different. So whenever you get this kind of question, volume, fluid volume calculation, you know that there is a formula which is known as the volume of distribution formula. Volume of distribution formula I have used, and there the volume of distribution, suppose that V. So, we know the formula V is equal to Q minus E upon C. I believe you remember this formula. Q is the total amount of substances which has been injected. So, this is Q. Okay. Amount of substances which is excreted, that is my E. Okay. And the final concentration of the substances after the substances has been distributed in the plasma or blood, that is C. Okay. Now, you put into this. Okay. So, Q is 120 minus 5 is excreted, all are in the same unit. So, I do not have to convert the unit, in milligram per ml देके रखा है. So, upon 0.01. So, this will be 0.01. So, it will be equal to 11500 ml. Up to this you got it? Okay. So, now one thing you have to be concentrate here. What you have injected? You have injected inulin. So, inulin is a substances which is used to determine which compartment volume of which compartment. Could you answer? If you inject inulin in the plasma, it will be distributed inside the plasma as well as interstitial fluid. दोनों में distribute होगा. It will be distributed in the plasma as well as in the interstitial fluid. That means the inulin which you have injected, that will measure the volume of ECF. So, this 11500 ml, this is the volume of ECF. But what is your question? Your question is asking about the calculation of the interstitial fluid. So, interstitial fluid means ECF minus your plasma volume. That is why the plasma volume has been given here. So, 11500 minus 3500, this is 8000 ml is the answer. Very good. ठीक है. So, देखो अभी तक यहाँ तक क्वेश्चन दिया नहीं है, बट ऑलरेडी दे हैव गिवन अ क्वेश्चन बेस्ड ऑन इंजेक्शन ऑफ सुक्रोज. Okay, sucrose was injected, this is the amount injected, this is the excreted, this is the concentration, calculate the volume of the ECF. Because sucrose is also used for calculating the ECF volume, same for the inulin, right? So, if that is the question, that is a direct question, but sometimes additionally they can ask you like interstitial fluid volume calculation. So, you have to subtract ECF minus plasma volume, that is all. I believe you got it. Okay. Now, next question, calculate the cardiac output based on this information. So, cardiac output calculation can be done by a mathematical equation which is known as the fixed principles. Okay. There are other method also, like dye dilution method is there, thermodilution method is there, based on another principle which is known as the Stewart-Hamilton principle. STEWART, Stewart-Hamilton principles, which is principles of the dye or thermodilution method. This question has also been asked in INI-CET already. Okay. Dye dilution method or thermodilution method is based on which principle? That is the Stewart-Hamilton principles. And it has also been asked which of the following methods are cardiac output measurement methods. So, you have to remember the dye dilution method, thermodilution method, fixed principles, echocardiography, all of them can be used for cardiac output measurement. But here looking at the value, you can easily understand that this cardiac output calculation will be based on fixed principle. So, fixed principle is saying that cardiac output is equal to oxygen consumption upon your artery oxygen minus venous oxygen. Now, here only one thing you have to do. here look at this thing, this is 20 ml percentage, means 20 ml per deciliter, 20 ml per deciliter. So, you have to convert this into 20 ml per ml, deciliter means 100 ml. So, this is basically 0.2 ml per ml of blood, and here it is 0.15 ml per ml of blood. Now, if you put it into this equation, 240 upon 0.2 minus 0.15. Now, you can easily understand 240, okay, calculation kar lo, 240 upon 0.05, it will be equal to 4800 ml per minute. So, that is 4.8 liter is the cardiac output per minute in these questions. Okay, ये done. Okay, next question. ये question last time का LRR में भी मैंने दिखाया था. Calculate the ejection fraction from the following graph. So, ejection fraction we all know, stroke volume upon end diastolic volume multiplied by 100 is the ejection fraction percentage. Okay. So, in this graph, I believe all of you know this graph. This is the pressure volume loop in the cardiovascular system, and in this pressure volume loop, this point number 4, this is the volume which is known as the end systolic volume, okay, and this point number 1, this is the volume which is the end diastolic volume. Okay, because I believe all of you know that this is the part which is indicating the filling phase of the ventricle, then this is the isovolumic contraction phase of pressure volume loop, then this is the ejection phase of the pressure volume loop, and then this is the isovolumic relaxation phase of the pressure volume loop, the isovolumic relaxation. So, basically this end systolic volume, end diastolic volume, the difference between these two is the volume of stroke volume. So, the stroke volume in this cases approximate leke chalo, so it will be approximate 75 ml, right? And then I have to look at what is the end diastolic volume. So, end diastolic volume is here, that is a 150 ml. So, end diastolic volume is 150 ml. So, obviously your ejection fraction is equal to 75 upon 150 multiplied by 100, that is 50%. Okay, simple question, no further discussion here. I believe all of you know this thing. Now, again a repeat question I have kept here. So, resistance flow calculation. So, here all of you know that the flow is inverse of resistance, and we calculate the resistance based on a mathematical equation pi r to the power 4, and this mathematical equation is known as the Poiseuille-Huygens equation. All of you know that thing. Okay. So, Poiseuille-Huygens equation you have to used here to calculate the resistance, and then flow will be reverse of that. Okay. So, you all of you know the answer. Okay. So, here you can assume that diameter of this vessel A is twice that of the vessel B. So, I can understand radius is also twice that of the vessel B, and here also suppose this is the R. Okay. So, how I am going to do it? So, I am calculating the resistance of A upon B, A upon B. So, I am going to do it. So, basically this resistance is length upon r to the power 4, ये ऐसे change हो रहा है ना. Okay, so I am going to write it like this. So, this will be 2L upon 2R to the power 4 upon L R to the power 4. Okay. So, obviously this will be 16R multiplied by R upon L. So, 1 upon 8. So, A upon B resistance is 1 upon 8. So, obvious thing is that flow will be reverse of this. So, flow of A upon B will be 8 times than that of the B. Okay. So, you calculate at your own space, but the answer will go in the same direction. You calculate directly flow, or okay, or you calculate directly the resistance followed by flow, answer will be the same, but it will go in the same direction like this. Okay. Diameter देके रखा है, उसको radius में change कर लो, उसके बाद you do the formula. Okay. Now, next one, the clearance calculation. Calculate the urea clearance from this following formula. New question, urea clearance. Okay. So, whenever you get the clearance formula, you know the formula, clearance is equal to UV upon P. So, U is the urinary concentration. So, this is the U, but I have to calculate this into 75 milligram per dl. Again I am repeating, in clearance formula or any formula whenever you are using, look at the unit. So, if you look at the volume of the urine flow, here it is given ml per minute, but the concentration of the urea that is given in the urine is milligram per dl. So, dl nahi chalega, dl is the deciliter, 100 ml. So, I have to convert it into ml. So, this will be 7.5 milligram per ml, 7.5 milligram per ml. Okay, I have calculated already, and this will be blood urea concentration. So, this is basically plasma urea P. P is equal to 0.15 milligram per ml. Okay, and this is basically my V, volume of urine. Now, one thing, this volume of urine formed that has been given here. Generally, you know, whenever you calculate the clearance of creatinine or clearance of urea, we basically collect the 24-hour urine sample. Okay, here in this question it is simplified. Urine volume V is already given in ml per minute. But sometimes, generally, normally what happens, normally urine is collected for 24 hours. So, sometimes in the question you may get that the volume of urine in 24 hour 1500 ml. Suppose this is given, then you have to convert that 1500 ml by dividing the 24 hour into minute. 24 hour को minute में पहले convert करो and then you convert the volume of urine in ml per minute. So basically आपका unit जो होना चाहिए वो है ml per minute में आपको लेके आना होगा. 24 आवर में दे दे, 1 आवर पे दे दे, जो भी है आपको उसको मिनट में कन्वर्ट करना होगा. ओके, एंड देन यू सिंपली पुट इनटू दिस फॉर्मूला. सो द क्लियरेंस इज इक्वल टू U V upon P. So U is here is 7.5 multiplied by 1 upon 0.15. Calculate कर लिया ना? हाँ, very good. This will be 50. Okay, 50 ml per minute. That is the clearance of urea in this case. Is very good. Okay, so everybody you are calculating, I believe. Okay, okay. Next question. Urine excretion calculation. So here, not the clearance, urinary excretion amount. So this question has already been asked in INI-CET. So suppose this is the glomerular capillary, and outside this glomerular capillary, this is the Bowman's capsule. This is the Bowman's capsule. Okay, plasma is flowing in this direction. First of all, they have given that the person has a GFR of 90 ml per minute. So in 1 minute, 90 ml plasma is getting filtered. And what is the blood glucose concentration? 200 milligram per dl. Again, I am telling that it has to be converted into milligram per ml. So basically, blood glucose has a concentration of 2 milligram per ml. Okay. So each ml of plasma is containing 2 milligram of sugar, blood glucose, and in 1 minute 90 ml plasma is getting filtered. So how much amount of glucose is going to reach here in 1 minute? This is known as the tubular load. So tubular load is equal to GFR multiplied by plasma concentration. So GFR is 90 here, plasma concentration is 2 here. So 180 milligram of glucose is appearing in Bowman's capsule in 1 minute. Now from here, transport maximum has been given. Generally, एक चीज सुन लो. Suppose transport maximum is given as well as renal threshold is also given. Then you have to use the renal threshold because that is the actual scenario. Transport maximum is a theoretical scenario, but in this question, because renal threshold is not given, we are taking the transport maximum. What is that? Transport maximum means from this amount of glucose which has been filtered at the level of Bowman's capsule, how much glucose is going to be reabsorbed. How much glucose is going to be reabsorbed, that is the T max here. But I told you, if T max as well as renal threshold both has been given, then I have to take the renal threshold value not the Tmax value, because Tmax is a theoretical concept, but actual is the renal threshold value. But here it is not given, so that's why you are taking 150 milligram of glucose has been reabsorbed from this 180 milligram. So obviously the remaining is going to appear in the urine. So how much is going to appear in the urine? 180 minus 150 milligram, that is a 30 milligram of glucose is going to appear in the urine. Getting my point? So this way you have to calculate the question. Okay, very good. Then the universal inherent question of INI-CET. Every alternate year they are going to ask a question from this titannizing frequency, either in the form of image or in the form of direct mathematical calculation. So here the single muscle twitch, skeletal muscle twitch has been given. So basically in skeletal muscle twitch, this is known as a simple muscle twitch or skeletal muscle twitch. So there will be a stimulus here, followed by there will be a latent period. After the latent period, there will be a period where the muscle is going to be contracted. So this is known as the contraction period, followed by there will be a relaxation period, followed by there will be a relaxation period. So whether it is given in the form of image or without image, what you have to do? You have to first look at that from which point the contraction is starting and at which point the contraction is ending. That's all. At which point the contraction is starting, at which point contraction is ending. That is your contraction period, and you require only the duration of the contraction period. So from the beginning of the contraction period up to the ending of the contraction period, what is the duration? This duration is known as the duration of the contraction period. And the formula for minimum titannizing frequency is 1 upon contraction period duration. 1 means 1 second, that is 1000 millisecond, upon the contraction period duration, that is 40 millisecond. So this will be 25 Hz is the minimum titannizing frequency. Latent period to maximum force of control. Latent period is not generally taken, only the duration of the contraction period, because in latent period if you give multiple stimulation, that is not going to affect the titannization. Okay, only the contraction period duration is taken. Okay, so 1 upon contraction period duration is the answer. Calculation of the gain of the control system. So gain we have discussed earlier that infinity gain is for kidney. Here you have to calculate the gain of the control system from this example. So suppose your blood pressure is here. So blood pressure, systolic blood pressure reduced by 10 millimeter when? Okay. So from here the systolic blood pressure reduced by 10 millimeter, 10. Okay. So this is the normal scenario, normal blood pressure, normal BP. It has reduced to 10 millimeter of mercury. Then by baroreceptor control system 8 millimeter already gain हो चुका है. Okay, but you can easily understand from here that only 8 millimeter raised हुई है, 2 millimeter of mercury ये अभी भी रह गया. So this is basically your error. And this 8 millimeter of mercury, this is basically your correction by the baroreceptor control system. So obvious thing is that gain is equal to correction upon your error. So correction is 8 upon 2, so 4. So it will be minus 4 because the correction is in the opposite direction, so it will be negative gain. Okay, correction upon error. Very good. Okay. Equilibrium potential calculation. Again an inherent question of INI-CET. So equilibrium potential formula you must have to remember R, T, Z, F. Every class, in every class I discuss this. So outward concentration of the ion, inward concentration of the ion. Okay. Then if you simplify this, it will be plus 61 upon Z log base 10 concentration of the ion outside, concentration of the ion inside. ठीक है? Okay. Now plus or minus in this question. Suppose plus 60 or plus 61 whatever, or minus 60, minus 61, both are given in the choices. So what will be your answer? Yes, but for normal potassium, what is the equilibrium potential? Potassium equilibrium potential normally is how much? Potassium equilibrium potential normally is how much? Normal mammalian cell, potassium has an equilibrium potential of how much? Answer batao. इक्विलिब्रियम पोटेंशियल ऑफ पोटेशियम इन नॉर्मल मैमेलियन सेल कितना होती है नॉर्मली, इसको भूल जाओ एवरीबॉडी, यस -90 मिलीवोल्ट, वेरी वेरी गुड, -90 मिलीवोल्ट, ओके। एंड इक्विलिब्रियम पोटेंशियल ऑफ क्लोराइड कितना होती है -70 मिलीवोल्ट। इक्विलिब्रियम पोटेंशियल ऑफ सोडियम कितना होती है +63 और 65 मिलीवोल्ट, ओके। ये नॉर्मल थिंग। व्हाई आई एम आस्किंग, because in this question the equilibrium potential of potassium which you are calculating will be positive, not negative. Why positive? Listen carefully. Whenever we are thinking of the equilibrium potential of potassium -90, this is the normal. Again and again I am saying, assuming the cell is normal mammalian cell. Normal mammalian cell में potassium ज़्यादा कहाँ पे होता है, ICM में कि ECM में? ICM में. Now you look at this question. In this question, intracellular potassium is 10, extracellular potassium is 100. Is it a normal cell? No. That's why in the question has mentioned it's a model cell. Okay. इसीलिए आपको थोड़ा सा केयरफुल होना होगा, जब भी हम ICF ECF को चेंज कर देंगे ना, तो ये जो नॉर्मल जो वैल्यू पॉजिटिव नेगेटिव था ये चेंज हो जाएगा, ओके। सपोज क्लोराइड concentration is more in outside, that's why it is minus equilibrium potential. If I change in a model cell, if I change the concentration, then it will be positive. Potassium, normally it is minus because ICF potassium is high, but in this condition ICF potassium is lower than ECF. So that's why the value will change. So step by step fashion, if you go in this equation, so it will be plus 61 upon plus 1, that is the potassium charge 10. Outside potassium concentration is 100, inside is 10. So 100 upon 10 is 10. So log 10 base 10 is 1. So this will be plus 61 or plus 60 millivolt. Getting my point? If you go in a step by step fashion according to this formula, then also you are getting positive. But sometimes in the exam you may get confused. So please look at the cell. Whether it is looking like a normal cell, then the sign will be normal. Okay, like potassium negative होता है, chloride negative होता है, sodium positive होता है, calcium positive होता है, ये normal sign. If the cell which is given in the question that is also like normal cell, means ECF ICF distribution is like normal cell, then equilibrium potential will follow this sign. But if you change the concentration between ICF and ECF, then the sign will be different. उल्टा हो जाएगा sign. ठीक है, ध्यान रखो. Actually, there is another way to remember this thing. So suppose you are thinking of this model cell. Suppose this is the model cell. Okay. Now check the ion concentration is more in which side, ICF or ECF. In this cell, potassium is more in outside. ये तो बोल दिया ना, extracellular potassium is high. So if the potassium is high in outside, suppose I have opened one potassium channel. So what the potassium will do? Potassium will enter inside the cell or potassium will go out of the cell. That is the thinking. If you think in this way, you will never miss the sign. So in this condition, potassium will enter inside the cell. Potassium is entering in the cell. What kind of charge is entering in the cell? Positive charge. If the positive charge is entering in the cell, which kind of cell's charge will be there? Positivity. And remember, inside क्या हो रहा है? What is happening inside the cell? That is the charge, which will be the equilibrium potential. What is happening outside? That is not the equilibrium potential. Equilibrium potential is what is happening inside the cell. Okay, inside the cell. So normally, suppose a normal cell, chloride concentration is more in the outside. Normal cell, ये normal cell, model cell नहीं है, normal cell. Chloride concentration is more in the outside. So if I open a chloride channel in this cell, what will happen? The chloride will enter. Now if the chloride is entering, which kind of charge is entering in the cell? Negative charge. So what will happen inside the cell? There will be negativity. So what will be the equilibrium potential of chloride in this cell? Negative. Sodium का equilibrium potential positive क्यों होता है? Look at the cell. Sodium is more in the outside, positive charge. If I open a sodium channel, what the sodium is going to do? Sodium is going to trickle down inside the cell. What kind of charge is entering in the cell? Positive. So equilibrium potential positive होगा. Calcium का equilibrium potential positive. Why? Because calcium is more in the outside. If you open a calcium channel, calcium will enter in the cell. That's why calcium equilibrium potential is positive. Potassium normal equilibrium potential is negative. Why? क्योंकि नॉर्मल सेल में पोटासियम का कॉन्सेंट्रेशन ज़्यादा कहाँ पे होता है? इनसाइड होता है. So if I open a potassium channel in a normal cell, potassium is going to go out of the cell. if the potassium is going out of the cell, what will happen inside the cell? Cell will lose positive charge. Cell lose positive charge means what will remain inside? Negative. That's why it will be negative potassium. अभी समझ में आया? Okay. ये कभी मिस्टेक नहीं करना है. अभी समझ में आया युवराज and all? ठीक है ना? So if you think this way, then even if you miss the equation, you are never going to forget कि what will happen to the positive और negative. दोनों ही देके रखा है, confusion बिल्कुल नहीं होगा. सोच लो कि सेल में एक चैनल को ओपन कर दिया तो इंटीरियर सेल का इनसाइड में क्या होगा, ये सोच लो बस. ओके, सो ये हो गया हमारा मैथमेटिकल कैलकुलेशन. नाउ इंपॉर्टेंट इमेजेस. ओके, सो मोस्ट ऑफ द इंपॉर्टेंट इमेजेस यू नो. ओके, एंड दोज इमेजेस आर नॉट वेरी टफ, सो दैट्स व्हाई वी विल डिस्कस little bit faster way. So first question, action potential. I believe all of you know the ionic basis of this action potential. So quickly, if I say that what is the cause of this depolarization in the action potential of the neuron. So this is the action potential of neuron and skeletal muscle, both are same. Okay, so this is due to sodium entry, sodium influx, and then the repolarization part, this is the repolarization part including the after hyperpolarization, this is potassium exit और okay, and ये जो रेड पार्ट इसको हम लोग बोलते हैं लेटेंट पोटेंशियल. ओके, सो ओनली थिंग इज दैट डीपोलराइजेशन is because of sodium influx. What kind of sodium channel this is? Sodium channel which is responsible, it is the first sodium channel, and repolarization is potassium efflux. Okay, voltage gated potassium, it's a kind of slow channel, right? And sometimes they may ask you that what is the name of this phase? This phase is known as the after hyperpolarization. After hyperpolarization is due to which ion? Again this is potassium efflux. Okay, this is also potassium efflux, but due to the slow closure of the potassium channel, this hyperpolarization, after hyperpolarization occurs. Okay, simple thing, all of you know. Now similar to this action potential, sometimes this kind of question can be given. You have to identify A, B, C, what are they? Okay, now A, B, C में से first you look at the red color thing. So this red color thing is following a pattern where it is going upward and then it's going downward, and one part is going below the baseline. Below the baseline means ये जो black color line ये हमारा basically RMP है, RMP से नीचे जा रहा है. So this is the A. So A is basically action potential, the action potential which we have already discussed. Now I told you that during action potential, if you look back on the previous diagram, during action potential depolarization is due to sodium influx, entry of sodium. Now if I ask you that during repolarization, during this part, sodium entry is happening or not? Sodium channel is completely closed or some of the sodium channels are still open? Suppose this is my question, that during this part, this is due to efflux of potassium, but is the sodium channel is completely closed during this part? Answer is no, because if you look at here, okay, sodium channel opening and closing, that is shown in this curve number B. So curve number B is sodium permeability, or you can say sodium conductance, Okay, so during depolarization, this is the phase during depolarization. What is happening to the sodium channel? Sodium channel is opening more and more, means the number of the sodium channel opening is increasing. That's why the green color curve is going in the upward direction. And during repolarization, sodium channel is not opening further. Some of them are still open, but what is happening? The sodium channel is going for more and more closure, closure nahi, basically inactivation followed by closure. So This green color curve, what it is showing? It is showing the number of the sodium channel opened at different part of the action potential. So, if I ask you maximum sodium channel is open in which part of the action potential? At the peak of the action potential, maximum sodium channel is open. Because during depolarization, number of the sodium channel opening is increasing more and more, and then this is the peak point where maximum sodium channel are open. So, maximum sodium channel opening point is corresponding with the peak of the action potential. Getting my point? During repolarization, not all the sodium channels are closed or inactive. Otherwise, this permeability curve will look like this. This permeability curve will look like this, but it is not looking like this. It is not directly coming down to 0. No, it is coming down to 0 in a different pattern. This different pattern indicate that even during this repolarization, sodium channels are still open, but potassium channel opening number is more than that of the sodium channel opening number. Getting my point? So, that is why remember that this is the permeability of the sodium, number of sodium channel open. So, maximum opening is happening here, then number of open sodium channel is decreasing, कम होते जा रहा है. Okay? Same way, the curve number C, the curve number C is the blue color curve, that is the potassium permeability during action potential, potassium permeability or potassium conductance, during action potential. I told you already that potassium channel opening curve is not following the sodium channel opening curve. Why? If you look at here, sodium channel opening is very fast, followed by inactivation is also very fast. But potassium channel, I told you already here that it is a kind of slow channel. So, slow channel means potassium channel opening will go in slow manner, followed by closure will also go in slow manner. Getting my point? So, looking at this curve, you can easily understand that this curve C is the potassium permeability curve and curve B is the sodium permeability curve and curve A is the action potential curve. Now, you tell me whether you got this thing or not. You got this thing or not? Okay, everybody, you got it? Okay, so potassium permeability, sodium permeability and action potential curve can be given. This has already been asked in INI-CET. Okay, chalo. Next question, very simple. I am not going to discuss much, but this question has been asked twice in INI-CET. Whenever you are getting this kind of electron microscopic image, okay, so this will be obliterated, this name will be obliterated and they will ask you which is what. Okay. So, first of all, you try to identify the most brightest portion in this sarcomere. Most brightest portion means that will be the I band, okay. And whenever you identified the I band, the middle part of the I band contain one dark color line and that is your Z line, okay. This question has been asked in INI-CET that from periphery towards center. So, from the Z line, if you go towards the center, center is the M line. So, from the Z towards the M, if you go, what you are going to get? First of all, you are going to get the I band, followed by you are going to A band, followed by you are going to H band, okay. So, and then you are going to get the M line, okay. So, first of all, you identify the brightest portion, that is your I band, okay, or you can say an isotropic band. At the center of the I band there is Z line. So, Z line means on this side this is the actin and this side also this is the actin, okay. And then you look at the A band. A band is nothing but the myosin band or thick filament band. Within the A band, if you look carefully, then you will find out that there is a little bit lighter portion within this A band, and this little bit lighter portion within this A band is known as the Heller band, H band, it is written here, H band, okay. And at the center of the H band there is a M line, okay. So, M's line is the center of the H band, okay. Now, if you look at the structure of the sarcomere, so that was the electron microscopic image. So, here is your M line, okay. Here is your M line or M band, okay, and here is your Z line or Z band, okay. And in between this two Z line or Z band, you are going to get the length of the sarcomere. So, this is your the length of the sarcomere, okay. Now, why I have kept this diagram here? Two important molecule you should not forget from the sarcomere diagram. One is the nebulin and one is the titin. Okay. So, titin is a molecule. Titin is a molecule. If you follow this red colored structure, if you follow this red colored structure, so it is connected from M line to Z line, okay, M line to Z line. As titin related myopathies are there, na? So that is why this can be in future MCQ. So titin molecule is one of the largest protein, M line to Z line connected होता है. And then nebulin. So nebulin क्या होता है? Nebulin is a structure which basically surrounds the actin. Actin जहाँ पे होगा, actin का tip से लेके. So if you follow this nebulin molecule, so this light color diagram that is given here, that is a nebulin. Nebulin basically is make a spiral connection, spiral barrier surrounding the actin molecule. So that's why we say that nebulin is connected from tip of actin molecule, tip of actin to Z line, tip of actin molecule to Z line. Okay. So nemaline myopathy, if there is mutation of this, there will be nemaline myopathy, and titin, you know, the dilated cardiomyopathy, hypertrophic cardiomyopathy, TBL is anterior. So that is all because of this titinopathy बोला जाता है. So these are the things that you have to remember, most important thing from sarcomere diagram. ठीक है? Okay. Next question. Now this is a new one taken from Genome. So only question they will give here, that from this diagram identify the tactile receptor which is Pacinian corpuscles. Identify which of the diagram indicate Pacinian corpuscles diagram, Pacinian corpuscles phenomenon. Okay. So simple, this diagram will be given and they will ask question that the recording has been taken from tactile receptors from our body. Identify the Pacinian corpuscles from diagram. A, B, C, D your option. So which is the Pacinian corpuscles. Now my first job is to look at the diagram carefully and try to identify the leveling first. Okay, leveling first. So neural spike train, very difficult language. Neural spike train means spike potential. Spike potential means they are nothing but the action potential. So action potential diagram, what we have seen in books is generally like this, upward and downward, but here it is not following. So that's why there is a confusion. Action potential should look like this, but action potential depolarization and repolarization, if it is coming in the same line, then it will looks like a single line. Getting my point? So action potential diagram, okay, if the recording drum, if the recording screen is not moving, then depolarization and repolarization, they will fall on the same line, and then single line will be the action potential diagram. Means this is a basically action potential diagram, spike trend. This is another action potential, okay, this is another action potential, okay, this is another action potential in this diagram. Getting my point? Next, in the lower part of the diagram stimulus is given. So what is the meaning of this kind of stimulus? Stimulus is given means, first of all you identify what is the baseline of this stimulus. What is the baseline of this stimulus? So this is the baseline of this stimulus, okay, baseline, this is the baseline, okay. So this is baseline, okay. Now from the baseline I can understand that the stimulus intensity is increasing, and then you are maintaining the stimulus for some time, So what is x axis? X axis is the time, okay. That means look at me. Suppose tactile receptor means what will be the stimulus? Touch will be the stimulus or pressure will be the stimulus. So suppose with this pen I am giving a touch on my skin, okay. So whenever I am giving touch, there will be depression on the skin surface. Suppose I am measuring that depression, how much depression is happening on the skin surface, 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter. So whenever I am giving more and more touch, more and more indentation, so I am measuring how much depression is happening, and that depression I am plotting here. Suppose this is 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter. That is the stimulus strength, stimulus intensity. And then after 3 millimeter depression on the skin, I am maintaining that same stimulus for some time, maybe 2 seconds, maybe 3 seconds, maybe 5 seconds, whatever. This is the meaning of the stimulus. So if I give stimulus 1 millimeter, 2 millimeter, 3 millimeter, and then if I maintain the stimulus, what is happening to the action potential generation at the level of the receptor or nerve fiber? That I am plotting, that I am recording. So action potential generation कहाँ पे होता है? रिसेप्टर में होता है कि न्यूरॉन में होता है? ये न्यूरॉन में है, ओके. रिसेप्टर में डिपोलराइजेशन होगा, एंड देन आफ्टर डिपोलराइजेशन न्यूरॉन में एक्शन पोटेंशियल जनरेशन होगा. बट suppose I am giving a stimulus like this, okay. So, this is the stimulus that I have explained already, okay. And whenever I am holding the stimulus for long duration, okay, I am finding out that the action potential is vanishing, action potential is disappearing, okay. Try to understand. So, whenever I am increasing the strength of stimulus, I am getting huge frequency action potential 1, 2, 3, 4 huge frequency action potential I am getting. But whenever I am holding the stimulus for long duration, whenever I am holding the stimulus for long duration, okay, like this, I am finding out that the action potential is disappearing. Action potential is disappearing. What is the meaning? Meaning is that although you are stimulating the skin in the same manner, although you are maintaining the stimulus for some times, but action potential is disappearing. Why? Because of the adaptation of the receptor, because of the adaptation of the receptor. Okay. Suppose you are getting this kind, then you are understanding the receptor is getting adapted, because of which the action potential is disappearing. Okay, this happens. Like for example, whenever I am wearing this shirt for the first time, shirt, नया shirt पहन के आपने बाहर जा रहे हो. So, whenever you are wearing the shirt for the first time, you will understand that there is some kind of stimulus here, there is a kind of itching here, there is a kind of itching here. But after 1 hour, you forget that there is something in your collar, there is something in your hand. Why? Because the receptor which was giving this feeling of touch, giving the feeling of irritation, those receptor will get adapted. And whenever the receptor is getting adapted, action potential in the neuron, they will disappear. And if there is no action potential, you are not going to feel it, because brain is going to understand the action potential. That is the phenomena which is known as the adaptation phenomena. So, adaptation means there will be some change in the receptor, because of which action potential will disappear, because of which our perception will also decrease. That is adaptation in a gross manner. Okay. Now, suppose in a different receptor recording, I have given the same kind of stimulus 1 millimeter, 2 millimeter, 3 millimeter, and then I am holding the stimulus for long duration. But what I am finding out in these cases, that action potential is not disappearing, it is appearing in the same manner like that of not disappearing. So, what I will say, in these cases, are the receptor is adapted? Answer is not. Because of which we say that in the second cases, the receptor is a kind of slowly adapting receptor. Why slowly adapting? It is not getting adapted. It is not getting adapted within 2 seconds. Maybe if you hold it for 1 hour, it will get adapted. So, adaptation will happen, but in a slow manner. Within this 2-second period, within this 3-second period, when I am holding the stimulus, receptor is not getting adapted, action potential frequency is not decreasing at all. That indicate receptor is not slowly adapting. But whenever the action potential is disappearing immediately after holding 2 seconds or 3 seconds, then we will say that this kind of adaptation is a kind of rapidly adapting phenomena. First of all, you tell me whether you get this explanation or not. Okay. Got it, everybody? Okay. Everybody got it? Okay. Now you tell me, most rapidly adapting receptor in our body, touch receptor, which one is most rapidly adapting receptor? What is the answer? Already we have discussed Pacinian corpuscles. Okay. Now you look at the disappearance pattern of action potential in all the 4 diagram. How the action potential is disappearing? Look at the pattern. How many action potential you are going to get counted? Here 1, 2, 3, 4, 5, 6, 7. Here many. Here 1, 2, 3, 4. Here. List the number of action potential means most rapidly adapting receptor, that is. Getting my point? So, which is the answer of Pacinian corpuscle in this diagram? Now, everybody tell me which is the answer of this question. Pacinian corpuscle, which diagram indicate Pacinian corpuscle? Most rapidly adapting receptor in the body means least number of action potential you are going to get whenever you are giving stimulus. Now, all of you will get answer C. Now, you look at the diagram which I have taken from Genong. Okay. So, in the diagram which is given in Genong, so this is Pacinian corpuscles look at this diagram. This is the diagram, Pacinian corpuscles, followed by second most rapidly adapting receptor. So, the most rapidly adapting receptor is the Pacinian corpuscle, followed by Meissner corpuscles. Okay? So, that is why you will get number of action potential here. It is also less, but not the lesser than that of the Pacinian corpuscles. Okay? Followed by you will get the slowly adapting receptor. So, Merkel's is a slow adapting receptor and Ruffini's is also a slow adapting receptor. Okay. So, generally रैपिडली अडेप्टिंग रिसेप्टर को हम लोग बोलते हैं शॉर्ट फॉर्म में RA, रैपिडली अडेप्टिंग रिसेप्टर RA एंड स्लो अडेप्टिंग रिसेप्टर SA. आप बोलोगे ऑब्वियसली ये तो शॉर्ट फॉर्म ही है, स्लोली अडेप्टिंग रिसेप्टर. नाउ RA1, RA2, if the question is difficult then they will ask this kind of question, RA1, RA2, SA1, SA2 is which one? So, first of all, rapidly adapting, slowly adapting, you are understood, rapidly adapting receptor Pacinian, Meissner's, and there is another one, that is rapidly adapting receptor Pacinian, Meissner's and hair end organ. Okay. And slow adapting receptor mainly Merkel's, Ruffini's and free nerve ending, but at least you have to remember Merkel's and Ruffini's. Now, you look at the all four receptor and you look at the receptive field of all of this receptor, receptive field of all of this receptor. Here is the receptive field. What is the meaning of receptive field? If I give a stimulus, from which region the receptor can be picked up, the stimulus can be picked up by the receptor, that is the receptive field. Means एक receptor का कितना field से वो reception को pick कर सकता है, that is the receptive field. Suppose there is one receptor, from how much area, from how much square centimeter area it can pick up the sensation, that is the receptive field. Smallest receptive field is for which tactile receptor? Look at the diagram from Genong and answer. Everybody, if I ask you smallest receptive field for which tactile receptor, what is your answer? Smallest receptive field, ये चारों आपका ऑप्शन, Meissner, Merkel's, Pacinian, Ruffini's. What is your answer? Smallest receptive field from this diagram from Genong. So, that is the Merkel's. Merkel's has the smallest receptive field. So, between these two slowly adapting receptor, if I have to give number 1, I will give SA1 to the smallest receptive field and SA2 is this. Same way, if I look at the rapidly adapting receptor Pacinian मेरे को दिख रहा है, Meissner's दिख रहा है. दोनों में से किसका receptive field छोटा है? Which one has the smaller receptive field? That is Meissner's. So, it will be known as the RA1, it will be known as the RA2. Getting my point? So, number 1, number 2, ये जो number है, this number is based on the receptive field size. Smaller the receptive field, smaller is the number. Larger receptive field, larger is the number. So, between two slowly adapting receptor, if I have to number slowly adapting receptor, if I have to number between two slowly adapting receptors, smaller the receptive field, smaller is the number. Same for rapidly adapting receptor. Okay. So, this way S1, S2, RA1, RA2 number is given. Why I am explaining this thing? Now, you look at, this is the reference I have taken from Candle textbook of neurophysiology, which is a world renowned book of neurophysiology. Okay. There it has been explained that Merkel cells, this is SA1 receptor, Meissner's, this is RA1 receptor, and their receptive field, how the receptive field is distributed in different parts of the hand. Now, in these cases, they are describing two things, 2-point discrimination. What is the most important property of the receptor which will determine the 2-point discrimination property? The receptive field. Receptive field जितना smallest होगा, that will be the best receptor for detecting 2-point discrimination. Getting my point? Why I am discussing? So, 2-point discrimination will be maximum for which receptor, or 2-point discrimination will be best done by which receptor? The receptor which have the smallest receptive field. And what is the answer of that? Right, Merkel's. Got it? Okay. Now, next one, reading of Braille dots. It is taken from books. It is written that the Braille dots, they are separated by 3 mm apart. or 2 millimeter, 2 to 3 millimeter upward, the bell dots are there. So, if I have to perceive that dot as a separate point, I require a receptive field which is smallest. Otherwise, if both the dot is falling within the same receptive field, then brain will perceive it as a single point rather than 2 point. But if the 2 point is falling on 2 different receptive field of the receptor, then the brain will perceive them as a 2 different points. So, this will be perceived as 2 different point in the brain, but this will be perceived as a single point in the brain. So, that is why this book has described that SA1 fiber is the best to pick up the dots of the braille. So, SA1 is which receptor? That is the slowly adapting Merkels. So, that is why I told that for braille as well as for 2 point discrimination, the best receptor is Merkels followed by Meissner's. Now, after this, if you want to make confusion, you allowed to do that, but this is the explanation from the most authentic neurophysiology textbook in worldwide, that is Candle textbook of neurophysiology. Okay, you can check yourself also. Okay, so you should not make confusion here, believe me. Okay, chalo. Next image. So, next image we are not going to discuss much because all of you know that this EEG wave, you must have to remember the frequency of this EEG wave. Okay, the frequency of the EEG wave you must have to remember, and what condition will produce this beta wave, alpha wave, okay, delta wave, theta wave, all these things you have to remember. Okay. So, how to identify which wave this is? I told you repeatedly in my other classes also that look at the x axis. Look at the x axis, there must be a time scale given, and within that time scale, suppose this is a 1 second period given in your diagram. So, within that 1 second period, you try to count how many peak of the wave you are getting. That will be the frequency of the EEG wave. And if you are not able to getting the frequency because you are getting a baseline which is looking like this, that means that is a very high frequency, that is why you are not getting any peak. Okay. Suppose you are getting a line like this where you are not able to count how many peaks are there, that indicate very high frequency. Okay. Otherwise, look at this diagram, you can easily identify how many peaks are there within 1 second period. So, this way you can identify what is the kind of wave in the EEG. But obviously, this is a simplification. Diagnosis from EEG is a little bit more difficult. I believe the medicine teacher will tell you in better way that, okay, because there are some catch EEG type also, okay, that you have to do. But for physiology, this is more than enough. And next thing, this has been asked recently, the phenomena of alpha block phenomena. So, whenever a person is closing his eyes and whenever his mind is wandering here and there, mind is not concentrating on a single point, mind is wandering, okay, then what kind of wave you are going to get? You are going to get the alpha wave. Okay. So, suppose you have closed your eyes, okay, suppose in this class you are not listening, okay, your mind is wandering, you have closed your eyes because आपको लग रहा है कि सर क्या बोल रहा है, समझ में नहीं आ रहा है. So, you have closed your eyes and you are thinking that you will go for movie, you will go with your girlfriend or something like that. So, your mind is wandering here and there, you are not concentrating. What kind of wave you are going to get? Alpha. Now, suddenly suppose I told you, hey, hello, look at here. So, what you will do? You will suddenly concentrate that what sir is saying, dekhte. Okay. So, whenever you are opening your eyes and you are trying to concentrate on your YouTube screen, then this alpha wave will be converted into high frequency wave, that is the beta wave. Okay. So, that is why here whenever you are opening your eyes and you are trying to concentrate on something, then your alpha will be converted into beta wave, high frequency wave. So, this phenomena is known as the alpha block phenomena or phenomena of arousal. Okay. You are about to sleep, but suddenly you are aroused from that condition. So, phenomena of arousal or phenomena of desynchronization. Are you going to remember this word? Yes. Alpha block phenomena or desynchronization. Desynchronization phenomena or phenomena of arousal. Okay? So, this thing you have to remember. Okay. Now, the universal diagram. Okay. Oxygen hemoglobin dissociation का left shift, right shift, हैना तेना बहुत सारा चीज. I believe all of you have mog up all this thing, but look at this diagram a little bit carefully. So, suppose all these 4 curves has been given and it has not been marked. You have to identify which one is a fetal hemoglobin curve. So, you all know the fetal hemoglobin curve is left shift, carbon monoxide curve is also left shift, okay, myoglobin curve is also left shift. How to identify? The shape of the fetal hemoglobin curve will be following the adult hemoglobin curve. Okay, only difference is that it will parallelly shift to the left side a little bit. That means in the adult hemoglobin curve, there is a point here, that is the 50% saturation point. 50% saturation point, the partial pressure which is required, what is the name of that thing? What is the name of this, or what is the value of this? 50% saturation. ये जो मैंने perpendicular drop किया 50% saturation, okay, partial pressure which is required for this 50% saturation. What is the name of that thing? Partial pressure. Very good, very good. At least you have answered the number. So this is known as the P50 of hemoglobin. P50 of normal adult hemoglobin is 23 to 26 millimeter of mercury. And if you calculate the P50 from fetal hemoglobin, P50 of fetal hemoglobin, कौन आंसर बताएगा? What is the P50 of fetal hemoglobin? Value बताओ. Okay, P50 of fetal hemoglobin is 19 millimeter of mercury. 19 millimeter of mercury. Very good. ठीक है. So इसलिए देखो, only the P50 point will be shifted towards the left side a little bit. Otherwise, the curve will follow the same adult curve. But myoglobin has a typical shape of the curve, and that curve is known as the rectangular hyperabolic kind of curve. Rectangular hyperabolic kind of curve. So myoglobin curve को देखो, ये जो है ना, इसको हम लोग बोलते हैं rectangular hyperabolic kind of curve. It is not left shift. It is not following the pattern of the adult curve. Okay, it is not sigmoid shaped curve, but it is a rectangular hyperabolic curve. And the leftmost curve, सबसे लेफ्ट में जाके जो शिफ्ट हो जाएगा, उसको हम लोग कार्बन मोनोऑक्साइड कर्व मान के चलेंगे. ओके, सो इसलिए देखो इन दिस डायग्राम जो लेफ्टवर्ड मोस्ट कर्व है वो हमारा कार्बन मोनोऑक्साइड कर्व है. ओके, एंड दीज आर द कॉज ऑफ द लेफ्ट शिफ्ट ऑफ द ऑक्सीजन हीमोग्लोबिन डिसोसिएशन कर्व. सो आई बिलीव ऑल ऑफ यू नो द आंसर ऑफ दिस क्वेश्चन. द लेफ्ट शिफ्ट का कॉज क्या क्या होता है? सो फीटल हीमोग्लोबिन, स्टोरेज ऑफ ब्लड, कार्बन मोनोऑक्साइड पॉइजनिंग, मेट हीमोग्लोबिन, थैलासेमिया, ऑल दिस थिंग यू हैव टू रिमेंबर. ओके, सो स्टोरेज ऑफ ब्लड में 2,3 DPG कम हो जाता है. फीटल हीमोग्लोबिन में गैमा चेन होता है, बिकॉज हम लोग जानते हैं कि 2,3 DPG जो होता है that binds with the which chain of the hemoglobin? Beta chain of the hemoglobin. And once they have been asked in INI-CET, then 1 molecule of hemoglobin, 1 molecule of hemoglobin binds with 1 molecule of DPG, 2,3 DPG. So 1:1 ratio में bind होता है, and binds with which chain of hemoglobin? Beta chain of hemoglobin. This many information is required. Okay. Next curve, compliance curve. So compliance we have already discussed. What is the meaning of compliance? It is the delta V upon delta P. So देखो टॉपिक सेम ही है, सेम टॉपिक से डिफरेंट क्वेश्चन दे रहा है. पहले compliance we have calculated the mathematical calculation. Now they have given compliance curve. So what is this? This is x axis is the pressure and y axis is the volume. So volume change in respect to pressure change, that is compliance. So here the normal curve has been given. One curve which is above the normal curve, so this indicates this is the high compliance lung condition, high compliance lung condition, and the answer to this is emphysema, okay, and asthma also, little increase, okay, but not all obstructive disease will have high compliance, emphysema and asthma. Suppose I am saying of bronchitis, it is normal compliance, normal lung compliance, because bronchitis is a main problem of the upper airways, not the alveoli level. Okay, so उस condition में compliance will remain almost normal. ठीक है, emphysema compliance will be always high because of the destruction of the alveoli. Elastic tissue is destroyed. That's why the lung will be loose and lax. Compliance will be high. Same for chronic asthma. Okay, same for chronic asthma, but compared to emphysema, asthma will have less higher compliance. Okay, and compliance will be lower in all case of restrictive disease. So I should write down all restrictive disease, whether it is parenchymal restriction, like for example fibrosis, or it is extra parenchymal restriction, like for example myasthenia gravis or all this thing. In every cases the compliance will be lower. ठीक है? Okay, bottom line. चलो. Now next is the diagram of the Valsalva maneuver. So Valsalva maneuver, you have seen in medicine there are different kind of murmur which will be increased during Valsalva maneuver, there will be decrease in some of the murmur. So what is Valsalva maneuver? All of you know that if I close my glottis and if I try to forcefully expire, That is the Valsalva maneuver. So whenever I am expiring forcefully, what is happening in my chest wall? The chest wall is getting compressed. Okay. So try to look at. So upper part of this diagram is esophageal pressure. Esophageal pressure. Esophageal pressure is a surrogate of the intrathoracic pressure. Intrathoracic pressure. Okay. So you measure the pressure from the middle part of the esophagus, that is a surrogate of your intrathoracic pressure. So starting point of the Valsalva means suddenly the intrathoracic pressure is raised. Now after raising the intrathoracic pressure, you are holding the high intrathoracic pressure for some times, and then suddenly you are ending the maneuver, that is the stoppage of the Valsalva maneuver. Okay. So during Valsalva maneuver, what you are doing? You are raising your intrathoracic pressure, then you are holding that high pressure for some times, and then you are releasing the pressure. High pressure like this, 10 second, 15 second, and then you suddenly release. If you look at the blood pressure diagram, blood pressure is following a particular pattern. What is that pattern? Try to identify. Try to look at this line. At the initiation, there is a little increase in blood pressure, then there is decrease, then there is further decrease, then there is sudden increase, and like this. Means if I draw the blood pressure diagram, blood pressure immediately there will be a little increase, then there will be decrease, then at the release of the pressure, blood pressure will further decrease, and then suddenly increase, and then stabilize like this. Okay. So blood pressure pattern, first there will be increase, that is known as a phase number 1, then there will be decrease significantly, then there will be further decrease, phase number 3, and there will be high blood pressure, that is phase number 4. This is the different phase of the Valsalva, phase 1, phase 2, phase 3, 4, 4. So phase 1 of Valsalva, why there is increase in blood pressure? Due to compression on pulmonary vessels. I will explain. So whenever you are starting the maneuver, try to think of, suddenly you are compressing your thoracic cavity. So what will happen to lungs? Both the lungs will be as if the lungs are squeezing out. What is there inside the lung? Air and blood vessels. So if you compress the lung, the blood from the lungs will be squeezed out, and lung se blood squeeze out hoga to where the blood will go? The blood will go to the left side of the atrium. So that's why there will be more blood whenever you are compressing the thoracic cavity. Immediately there will be more blood on the left side of the heart. More blood on the left side of the heart means cardiac output in the arch of aorta will be higher. Cardiac output higher means blood pressure will be higher. So that's why increase in blood pressure in phase 1 is due to compression of pulmonary vessel, which will squeeze out extra blood from the vessels to the heart. That is the explanation. Now if I maintain the high compression on the thoracic cavity, immediately there will be squeeze out. But if I maintain this for 10 seconds, 15 seconds, so high blood pressure will not maintain for 10-15 seconds, because whenever you are compressing your thoracic cavity, blood from the lower part of the body, blood from the upper part of the body will not be able to return to the right side of the heart. Getting my point? You are compressing the thoracic cavity, you are compressing the heart. Where the blood will return? Superior vena cava, inferior vena cava, ultimately blood is returning to the right side of the heart, right atrium. But if you compress the thoracic cavity, you compress the heart for long duration, returning of the blood to the right side of the heart will be decreased. That is known as the decreased venous return. So because of the decreased venous return to right side of the heart, what will happen to the blood pressure? The blood pressure will be significantly decreased to phase number 2. And this is the phase of Valsalva which is generally used in medicines. Some murmur will increase in Valsalva, some murmur will decrease in Valsalva. Which phase of Valsalva they are talking about? The phase number 2, that is the main phase of Valsalva. Okay. So whenever you are holding this pressure for long duration, the venous return will decrease, the blood pressure will decrease, that is the actual phase of Valsalva. Now after compressing this thoracic cavity for 10 to 15 seconds, suddenly if you release the thoracic cavity, that is the end of Valsalva maneuver. What will happen? Suddenly if you released, there will be dilation of the pulmonary vessels. Now already the vessels in the pulmonary vessels was squeezed out. Squeeze out hone ke baad you are compressing the thoracic cavity. So vessels was compressed. Now suddenly you have released the pressure. So suddenly the vessel is opening up again. what will happen whenever the pulmonary vessels is opening up again, okay, there will be pooling of blood, extra blood in pulmonary circulation, Now, whenever there is extra pooling of blood in the pulmonary circulation, more blood is staying in the pulmonary circulation. So, what will happen to the blood in the left side of the ventricle? Left ventricular blood will be reduced, and if the left ventricular blood is reduced, what will happen to BP? BP will reduce further. So, that is why this phase number 3, why there is further reduction of blood pressure, although that is not much, but there will be a little decrease, further reduction of blood pressure, and this further reduction of blood pressure is due to pooling of the extra blood in the pulmonary vessels when the compression on the thoracic cavity is relieved, right? And then whenever everything is normal, that is the phase number 4. Phase number 4 means everything is normal. You have compressed your thoracic cavity, then you have released, and now you are relaxed. You have ended your Valsalva maneuver. Now tell me, during Valsalva maneuver, which kind of activity your body, which kind of activity will be there in your body, sympathetic or parasympathetic? Sympathetic, because you have to compressed thoracic cavity. Now whenever you have relieved everything, sympathetic activity is still high. If the sympathetic activity is still high, what it is going to do? Sympathetic system will causes vasoconstriction. Vasoconstriction means there will be increase in venous return. If there is increase in venous return, what will happen? Increase in cardiac output, and that will lead to increased blood pressure. That is why phase number 4 means increased blood pressure will be seen during release of maneuver. Got it? So, these are the different phases of Valsalva. Now, I believe if this is given as an image based question, or if it is given as an explanatory question, you will be able to answer different phase of Valsalva, but I told you the Valsalva phase that we generally talked about is the phase number 2. Okay. Now, coming to the action potential diagram, I believe all of you know the ionic basis of this. So, we have previously discussed the action potential of neuron. Now, this is the action potential of myocardium. So, this is sodium, then phase number 1, this is phase number 1, all of you know this is potassium exit. Okay. Then all of you know that this is phase number 2. Phase number 2 is entry of calcium as well as exit of potassium, and phase number 3, this is phase number 3, exit of potassium. So, arrow ka direction means exit, outward upward arrow means exit, inward arrow means entry. Now, why I have kept this diagram? The left sided diagram, although it has been asked in multiple times in MCQ, I believe all of you know that. But on right sided diagram, this is the nodal tissue action potential, this is the nodal tissue action potential. Now, in nodal tissue action potential, this part is known as the prepotential. This part is known as the prepotential phase. Okay. Followed by this is the phase number 0, and followed by this is the phase number 3. Okay. So, phase number 0, this is calcium entry, okay, and phase number 3, this is potassium exit. Okay. So, phase number 0 in case of myocardium, this is sodium entry. Phase number 0 in case of nodal tissue, that is the calcium entry. Two big difference, phase number 0, दोनों में big difference है, ये आपको ध्यान रखना होगा, ठीक है. But more important thing is that what is the cause of this prepotential? What is the cause of this prepotential? Number 3, 3 things you have to remember. Sodium entry through HCN channel. I believe all of you know this thing, funny current, yes, funny current. And what kind of sodium channel? This is slow sodium entry. Second, calcium entry, T-type calcium channel, but that is rapid calcium channel. Okay. And number 3, decrease potassium permeability in nodal tissue cell membrane. Decrease potassium permeability in nodal tissue cell membrane. These are the 3 things that you have to remember about, prepotential. So, prepotential is due to sodium entry followed by calcium entry, and along with that decrease potassium permeability means potassium channel closure will be there. Okay. But calcium entry which is happening in the prepotential, it is a kind of rapid calcium entry, but calcium entry which is causing depolarization phase, this is a kind of L-type slow calcium entry. Okay, so please remember that if the question is depolarization phase of nodal tissue is due to which ion, your calcium is the ion answer, but which kind of calcium? L-type calcium channel, which is a slow calcium channel. But whenever it is pre-potential, that is a rapid T-type calcium channel. ये चीज़ एक्सप्लेन करने के लिए मैंने डायग्राम रखा था, सो दिस इज डन. नाउ कार्डियोवास्कुलर सिस्टम में और एक डायग्राम दिया जाता है फोनोकार्डियम के साथ ईसीजी. हाउ टू आइडेंटिफाई? सो फोनोकार्डियोग्राम डायग्राम दैट इज गिवन हियर. सो दिस इज द डिफरेंट हार्ट साउंड recording. Okay, and below the ECG diagram, electrocardiogram diagram is given. So heart sound and electrocardiogram. So first heart sound will appear with R wave peak. Okay, second heart sound will appear end of T wave. Okay, fourth heart sound will appear end of P wave. Okay, ये ध्यान रखना होगा. Explanation is there, but इस क्लास में नहीं होगा for the time being. So whenever I am getting a heart sound which is corresponding with the R wave, so it will be my first heart sound. It will be my first heart sound. ठीक है. Whenever I am getting a wave heart sound which is falling on the end of the T wave, that will be my second heart sound. Okay, and P wave. This is the P wave. So a heart sound which is falling at the end of the P wave. So this will be basically my fourth heart sound. So obviously in between this will be the third heart sound. ठीक है. So this way you have to identify the heart sound. Okay. Now next one is the look at the filtrability at the glomerulus. This diagram has already been given in INI-CET. Okay. So if I get a diagram like this, first of all I am going to look at the x-axis. What I am going to look at the x-axis? Effective molecular radius in angstrom, means this 18 to 42. 18 angstrom means basically this is 1.8 nanometer and this is 4.2 nanometer. Angstrom को nanometer में convert कर लोगे तो यही होगा. So basically the diameter the radius of the molecule that has been given in this x-axis is ranging from 1.8 to 4.2. If you look at the information which is written on the right hand side, you can easily find out that this is the radius of the substances which is under the category of selective permeable substances. Okay. So this from 1.8 to 4.2. If the molecular radius of the substances is in between this range, then those substances are known as the selective permeable substances. If the radius is lesser than this, then this is a freely permeable substances. Charge is not a parameter in this condition. Freely permeable means whatever may be the charge, it will going to filtrate at the level of the Bowman's capsule, at the level of glomerular basement membrane. Okay. But whenever it is selective permeable, filtration depends on the charge of the molecule. How to identify from this diagram? You drop a perpendicular at this 226 angstrom. Drop a perpendicular at the 26 angstrom means all of the, if I drop a perpendicular here, all of these substances has an radius of 2.6 nanometer. So this perpendicular is cutting the red color curve at a higher filtration coefficient. Here it is cutting. So filtration coefficient is high. Then it is cutting the blue color curve at a lower range, and it is cutting the black color curve at a very lower range. Means I can easily understand, looking at this y axis, that the red color curve has a very high filtration coefficient, filtrability, followed by the blue color curve, followed by the black color curve, right. Now we all know that glomerular filtration barrier contain negatively charged. So if a substances is a negatively charged itself, then filtration will be lesser. So obvious thing is that the lowest filtration in this diagram is the polyanionic. Okay, polyanionic. So that's why looking at this curve, I can easily identify the charge. So this is anionic substances. this is cationic substances, and middle one is the neutral. Okay. So, this is basically your positively charged, this is the neutral, this is the negatively charged substances. Okay. So, this was given in the previous question. Okay. Now, coming to this acid base nomogram diagram, once it was given in INI-CET. Okay. Now, you have to remember this nomogram, that which zone is which kind of disorder. But there is an little bit idea from which you can easily identify. So, first of all, you identify the pH, normal pH. What is the normal pH? Acid base disorder you have read in medicine. So, 7.4 is the normal pH. So, you first drop on perpendicular from this 7.4. Okay. You drop on perpendicular from this 7.4. So, anything which is falling on this side, this is acidosis होगा, which is falling on the left hand side alkalosis होगा. ये तो simple, इसमें कुछ ये नहीं है. ठीक है. Now, next thing is that look at the bicarbonate. So, y axis is bicarbonate, and what is the normal plasma level of bicarbonate? Arterial plasma 24. Now, you drop another perpendicular from this 24, different color 24. Okay. Now, you try to understand, looking at this zone, what I can conclude? This is acidic zone obviously, and in this zone bicarbonate is above the normal value. यही तो ना, यही तो ना. So, in the pH equation from the Henderson-Hasselbalch equation, you know that pH basically bicarbonate upon your PCO2, PCO2. Okay. So, this is an acidic zone, means pH is less. So, pH is less, acidic zone means either the carbon dioxide will be high or bicarbonate will be lower. Okay. So, look at everybody. If I look at this zone, this is acidic zone also. This is acidic zone. But what is the bicarbonate level here? Bicarbonate is lesser than plasma bicarbonate. That means in this equation pH is lower and bicarbonate is also lower. So, which kind of acidosis this is? Metabolic acidosis. That is why in this diagram this is the metabolic acidosis zone. Getting my point? This is the metabolic acidosis zone. But whenever I am looking at this zone, this is acidic zone. But in this acidic zone bicarbonate is higher. So, higher bicarbonate means that is not the cause of the acidosis. That is not the cause of the acidosis. pH is lesser, acidic, but bicarbonate is higher. That means that is not the cause of the acidosis. But obviously the carbon dioxide should be higher. Now, try to identify the carbon dioxide curve from here. All this curve that is given here, these are the carbon dioxide curve. This is the carbon dioxide curve here. Okay. Identify. This is the carbon dioxide curve. So, this is the curve which is carbon dioxide curve. So, if I look at this zone, in this zone, look at this curve which is the carbon dioxide curve, which is higher than normal. What is the normal partial pressure of carbon dioxide? Normal partial pressure of carbon dioxide is 40. So, anything beyond this is above carbon dioxide zone. Means if I look at this zone, in this zone I can easily say this is acidic zone, carbon dioxide is higher than normal, bicarbonate is also higher than normal. So, obviously this is respiratory acidosis. Now, acute respiratory acidosis means bicarbonate will not be very much higher, but chronic respiratory acidosis means bicarbonate will be very, very higher. Getting my point? So, this way you have to identify. First of all, you identify that what is the normal value of bicarbonate. Sorry. First of all, you have to identify what is the normal value of bicarbonate. Okay. And then you identify the normal value of pH. Okay. Now, whenever this zones is separated, okay. So, anything which is falling in this zone, that is respiratory acidosis. Anything which is falling in this zone, that is metabolic acidosis. Got it? Okay. Now, if I look at a zone here, okay. If I look at a zone here, what I will think of? So, this is an alkalosis zone, and in this zone bicarbonate is higher than normal. So, alkalosis is because of the higher bicarbonate. So, what kind of alkalosis this is? This is metabolic alkalosis. And if I look at this zone, this is also alkalosis zone, but here the bicarbonate is lower than that of the normal, but obviously the carbon dioxide is also lower here. So, this alkalosis is due to carbon dioxide lowering, and this is known as the respiratory alkalosis zone. Getting my point? So, that is why anything here is the respiratory alkalosis, anything here is the metabolic alkalosis, and in between whatever zone you are getting, that is a mixed kind of disorder. Okay? So, this way acid base nomogram can be identified that what is the zone actually. Okay? This was given once in INI-CET and they have asked you to identify what is the kind of disorder in this zone. That was the question that was given. Okay? So, this way you have to look at. Okay. Next diagram is very easy one. Basic electrical rhythm. I told you already that basic electrical rhythm is very important for your MCQ. So, maximum frequency is duodenum followed by jejunum followed by ileum, that I have already told. Minimum frequency is at the level of cecum, but cecum sometimes not given. So, stomach will be the answer in that cases. So, in this diagram basic electrical rhythm is which one? So, this is the basic electrical rhythm. Okay. So, basic electrical rhythm means it is not going to causes contraction, no contraction, no contraction. But whenever at the surface of the basic electrical rhythm action potential is generated, so these are the action potential, these are the action potential, then and then only the contraction will start. Getting my point? So, basic electrical rhythm means no contraction, but whenever basic electrical rhythm is stimulated by neurotransmitter, then action potential will appear, and action potential means there will be contraction. So, what is the neurotransmitter that is going to cause action potential and contraction of the GI smooth muscle? Cholinergic stimulation. And if you give adrenergic stimulation, action potential will disappear and contraction will be reduced. That means smooth muscles of GIT will be relaxed. Based on the same principle, another question was given in the INI-CET, but here look at intestinal movement is given. In the previous diagram, basic electrical rhythm is a kind of electrical activity. So, electrical activity will be increased in presence of acetylcholine and it will be decreased in presence of adrenaline. Same for the mechanical activity. Mechanical activity will be reduced or decreased in presence of what kind of stimulus? Adrenaline. And mechanical kind of activity, suppose you are getting a kind of curve like this, suppose this is given like this, normal, followed by you are getting a curve like this, intestinal motility, intestinal contraction has been increased. This can be barium chloride, this can be CaCl, this can be ACH. Okay? Anything can increase the intestinal contraction, intestinal motility, but whenever you are giving adrenaline, the intestinal contraction will reduce. Got it everybody? This is very important. Twice this question has been given, this same color, same curve 2015 में दिया था और एक बार last to last year दिया था. Okay? So, this you have to remember. Now, next is the thyroid hormone and fasting. This curve was also given. In this, I have not kept any MCQ, but I told you how to remember that thyroid gland basically ये बेसिकली क्या सिक्रेट करता है? मेजरली ये T4 हार्मोन को सिक्रेट करता है, T4 हार्मोन. बट दिस T4 हार्मोन कैन बी कन्वर्टेड इनटू एक्टिव फॉर्म ऑफ T3 हार्मोन और इनएक्टिव फॉर्म ऑफ रिवर्स T3 हार्मोन. जनरली 33% हार्मोन of T4 converted to T3 and 45% converted to reverse T3. So, we all know that reverse T3 is a kind of inactive and T3 is active. Now, one of the most important function of the thyroid hormone is to increase the BMR. So, whenever a person is having fasting, that means in that cases, okay, obviously active T3 has no role because fasting means less amount of energy is going. So, what will happen in case of fasting? More amount of reverse T3 will be converted and less amount of T3 will be produced by peripheral conversion. So, that is why you know कि whenever a person is starting the fasting from this point, what is happening to the reverse T3 hormone, the reverse T3 hormone is increasing like this. Okay? And more the reverse T3 is increasing, that means inactivation is more. What will happen to the active hormone production? Active hormone production will reduce. So, that is why we say that these two curves are the mirror image of one another, T3 and reverse T3, mirror image of one another in case of fasting. And what about T4? T4 generally maintains normal level up to certain point of time, but if you do fasting for long duration, then T4 will also reduce, but in a slow manner. That is the diagram which is explained here. ठीक है, ये thyroid hormone का diagram. Next, I believe all of you will be able to answer this question, that different zones of the adrenal gland has been shown here and what is the hormone produced from this different zone, that you all know. So, I will not take much of the time, but just look at the adrenal medulla. Most hormone which is produced from adrenal medulla is epinephrine followed by norepinephrine, you know that thing, and in pheochromocytoma that is reverse, that you also know. But recently in INI-CET there was a question given that which of the following is a stimulus for epinephrine or epinephrine secretion except बोल के question था. So, this question has directly taken from this image from Genong. Okay. So, this is taken from Genong. This is the stimulus for plasma norepinephrine and plasma epinephrine secretion. दोनों हार्मोन का the stimulus is almost similar, but you have to note down one line. What is that line? This broken line. This broken line indicate this is the physiological point. Okay. So, look at this diagram. Resting in supine posture, okay, norepinephrine and epinephrine, both the level is below the physiological level. Okay. So, this is the physiological level ka point. Okay. If it is going beyond this, then we will say that this is going beyond the physiological limit. So, whenever a person is resting in a supine condition, epinephrine, norepinephrine levels are very less, below the physiological limit. But whenever a person is having hypoglycemia, or a person is doing exercise, or a person is doing is undergoing surgery, or ketoacidosis, myocardial infarction, pheochromocytoma, in all this condition you can find out that norepinephrine level is also rising as well as the epinephrine level is also rising. But which one is rising more? Which one is rising more? Epinephrine level is rising more than that of the physiological limit. Okay. That is why we say normal adrenal medulla secrete dominantly which one? The epinephrine one. Okay. So, look at this diagram carefully and try to interpret that you have to look at this physiological limit. So, there will be increase in epinephrine, norepinephrine both, but significant amount or beyond physiological increment is happening in case of epinephrine. So, exercise, hypoglycemia, including cigarette smoking, all of them are stimulus for epinephrine, norepinephrine release, but dominantly epinephrine release. This question has been given, all of the following are stimulus for epinephrine release except hyperglycemia was given in the choices. So, hyperglycemia is not a stimulus, hypoglycemia is a stimulus, even smoking is a stimulus, even standing posture is also a stimulus, and all this thing you have written here. So, this you have to remember. Okay. So, this is all about image based question. So, almost the class is done. At the last I have kept certain tables. I told you that in that table most of the things you have to a little bit mock up. Okay. So, what are the tables important? So, the locations of the SGLT and GLUT. So, all of you know this thing. So, I am not going to spend much of the time here, but again this GLUT4 is insulin responsive GLUT, you should not forget that, and I believe you know that thing. So, this one table. Second table we have already discussed that what are the substances used for measuring which part of the body fluid. Again this is an important table, sometimes direct question has been taken from this table, that which of the following is used for measuring total body water. So, this antipyrine has been asked in INI-CET. So, these names you should not forget, at least antipyrine, inulin, sucrose and iodine level albumin, these are the things that you must know from this table. Okay. Next table, classification of the nerve fiber. Again I believe this you remember because proprioceptive fiber, pressure touch pressure fiber, pain temperature fiber, these are the very important thing. And within this table A fiber and B fiber, all of you know that they are the myelinated fiber, and C fiber is the unmyelinated fiber, that you have to remember. And from A towards C if you go, the conduction velocity will decrease, as you can find out here. So try to remember the conduction velocity of this A alpha fiber that has been asked already in MCQ. Okay. So that is 70 to 120 meter per second. Okay. Next table, CVS hemodynamics. This is not that much important, but sometimes they are asking question that maximum blood flow per 100 gram of tissue in which organ? Okay. So kidney is the answer. Okay. Maximum oxygen consumption per 100 gram of tissue in which organ? Heart is the answer. So this way, try to look at the maximum thing. Maximum oxygen consumption per 100 gram of tissue, maximum oxygen consumption in 1 minute, maximum blood flow per 100 gram of tissue, maximum blood flow per minute. All of these things can be a separate MCQ, direct MCQ, which you must have to mug up from this table. Table from Gerong. So either you open Gerong or from this note, try to identify the maximum number. Okay? Okay. Now, important nucleus of hypothalamus. 2-3 nucleus are very important, but I will say try to recall all of them. There are many nucleus in the hypothalamus, but I have picked up only those which has already been asked and which are frequently asked, like reward center and punishment center. Very frequent MCQ in INI-CET in old days. Nowadays, they are mainly concentrating on this thermoregulation. More or less, they are concentrating on this thermoregulation. Okay, but previously they used to ask this reward center, okay, punishment center. So all these nucleus are important for your MCQ. Try to recall them, try to revise them. Okay. Thalamic nucleus. Recently there was only one question from here, so that's why I have jotted down all the important thalamic nuclei. Like for example, all of you know that VPL, ventroposterolateral and ventroposteromedial nucleus, they are part of the sensory system. Jitna sar ascending tracts hota hai, they goes through this nucleus. But lateral and medial geniculate body, all of you know from your ENT and eye that they are the relay station for the visual and hearing information. So this way they will ask you a question that which of the thalamic nucleus is responsible for or relay station for visual information. So your answer will be lateral nucleus for the vision and medial nucleus, medial thalamic nucleus for the medial geniculate nucleus for the, okay. But the question which they have asked is that cerebellum and basal ganglia, they connected in which nucleus of thalamus? Ventrolateral nucleus of thalamus. Okay. So this ventrolateral nucleus of thalamus, cerebellum and basal ganglia का जो nucleus है, afferent from cerebellum and basal ganglia, ventrolateral nucleus project to the primary motor area and premotor area. So it's form a feedback loop. Okay. And dorsomedial nucleus of thalamus control the eye movement. So this is also important for your future MCQ. ठीक है? Okay. Next table is endocrine receptor. Okay. And this is very important, believe me. Mogging up type of information, but they have already asked you. So G protein coupled receptor, GPCR, G protein coupled receptor. So there will be a G protein, followed by there will be an effector, that is adenylyl cyclase. They have also asked you the sequence, that what is the sequence of activation of G protein coupled receptor. So first there will be G protein activation, followed by adenylyl cyclase, followed by CAMP, followed by protein kinase A. This has been asked recently, that what is the sequence of G protein coupled receptor activation. So that is GS, that is the stimulatory G protein. For inhibitory G protein, same is the sequence, G protein followed by adenylyl cyclase, but here the adenylyl cyclase will be inhibited, because of which CMP level will be decreased and there will be inhibition of the protein kinase A. But this sequence is different in case of GQ. So this is also a G protein, that is a GQ type of G protein. It is connected with the phospholipase C rather than adenylyl cyclase, and followed by phospholipase C, inositol triphosphate and diacylglycerol will be activated. Then inositol triphosphate will release the calcium. So that's why we say all of these receptors, they act through the calcium, and this will activate the protein kinase C. Please try to remember the sequence. So if the G protein coupled receptor is activating the GQ type of G protein, then phospholipase C will be activated, followed by IP3, followed by DAG, and then protein kinase C. It will also release calcium. So what are the hormones that act through calcium release mechanism All of them are very, 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 very important. Okay. Now, here is a little confusion between this angiotensin 2 receptor. Angiotensin 2 has two receptor 81, 82. 81 receptor or 82, whatever you think, both of them can act through GQ also, GI also, but if you have to choose only one, go through this GQ type of receptor. Okay. Okay. Now, apart from this, another hormone receptor which is also important, we have previously discussed a little bit also, that through the JAK start pathway, growth hormone, prolactin and leptin. Some of you are telling ki leptin act through the JAK start pathway. So, this is a must know information. And some other hormone receptor like this MAP kinase pathway is insulin and IGF-1, that is the MAP kinase pathway. And RAS-RAP pathway, this is for EGF and NGF, epidermal growth factor and nerve growth factor. And previously they have asked multiple times that this ANP and nitric oxide, it act through which second messenger system, that is the CGMP. Okay. So, this is all about today's class. Last resort revision. So, I will share the PDF with my team and it will be shared with you. I will tell you that at least you look at the important topic that I have listed at the beginning of this thing, and the mathematical equation, the single liner and the all images that I have discussed here, you try to give a revision to them before going to the exam hall. Okay. Believe me, it will help you in your exam. Okay. So, this is all for today. Thank you so much. Okay. Thank you so much. Okay. So, I believe some information was new, some was repetition only, but try to revise this information before your exam, at least twice revision should be there. Okay. So, this is all for today. Bye bye, take care, good night.